There we go. Okay. So on behalf of Gintavenes Health Foundation, thank you for joining. Please, you still have time to invite a friend, family member, colleague, somebody who would benefit from the information that we'll be sharing this afternoon. Now, we will have a short welcome from the founder of Gintavenes Health Foundation, Dr. Andrew Agu. And here we go. Thank you.
Thank you, Flora. On behalf of the Board of Trustees of Gintavenes Health Foundation, our ardent supporters and facilitators, welcome to this, which is the fifth in the series of health education and promotion meetings that we've held. The purpose of these meetings are twofold: that healthcare professionals may peruse them and update their skills so they can care better for their patients, and that the lay public might be informed of all these disease processes so they, in the first place, prevent themselves from developing them. And if they do develop them, are informed of health education and promotion meetings that we've held. We will continue to put these meetings together, and we hope you'll be able to find them useful, share them with your friends, family, and contacts. We, like in most of the other meetings, have very experienced and eloquent speakers today, very experienced in their field of practice, and we hope you will stay to the end of the meeting to benefit and hear what they have to say. All our projects are funded by donations, and we hope you will find it in yourself to donate so that we can put more of these things together. Our project manager, Mr. John A. Sangbedo, will give you details on how to donate at the end of the meeting. Do have a good meeting. I will now hand you back to our able moderator, Ms. Flora Coker. Thanks for attending.
Thank you, Dr. Agu, for that welcome. Without further ado, we're going to go straight to our first speaker. Our first speaker today is Dr. Carol Gale. She's a consultant diabetologist working at King's College Hospital. Her areas of interest are diabetes in pregnancy, diabetes, and psychological health. Her other area of interest is system change and the development of community diabetes services. Over to you, Dr. Gale.
All right. Hello, everyone. So first, I'd like to thank Dr. Agu and Flora for inviting me to talk to you, and I hope that you're going to find the subject interesting. So I'm just going to go onto screen share and put this into slide mode. Right, can everybody see my screen? Should say diabetes diagnosis and risk factors.
Yes.
Okay, so Flora's very kindly introduced me, and what I've been asked to talk about is the diagnosis of type 2 diabetes and the risk factors that are associated with it. If I do have time, I do have a few slides on prevention. I did do a talk last year that was about pre-diabetes and prevention, and I know that it was uploaded on YouTube, and Flora can probably provide you the link at the end or put it up again. So in this slide represents what I call the spectrum of type 2 diabetes. So if you look at the very top, there's 3 boxes: pre-diabetes, type 2, and possible remission of type 2 diabetes. So we know now that you do move across these stages, and we know that at any of these stages, it is possible to either prevent or i.e. move from pre-diabetes back to normal, or type 2 diabetes to pre-diabetes or to normal, with interventions, lifestyle and diet and monitoring. So for the purposes, of this talk, what I'm going to focus on is explaining how we diagnose type 2 diabetes and the associated risk factors, and to put it in context, because with the increase in evidence and knowledge base, we know that we can make these substantial changes and protect people from the long-term consequences of type 2 diabetes and diabetes complications. So firstly, to say that the diagnosis of type 2 diabetes reflects changes in your blood glucose values that would be considered above the normal levels, or what is now termed pre-diabetes. We know from a long evidence base that these changes in your blood glucose values over the long term correlate with the risk of diabetes complications. So I'm going to spend a little bit of time on this slide. And there are 4 different ways of diagnosing type 2 diabetes. So firstly, I will say that that can be based on your blood plasma glucose values or on something called HbA1c. So the blood glucose values can be described in terms of milligrams per deciliter or millimoles per litre, and I'll be including the values for both of those. For what's called the HbA1c in the UK, we use that term. A1c is the same term used in America, or you may see it in books called glycated hemoglobin. So it's 3 terms for exactly the same measure. Internationally, this is standardized, whether that's UK, USA, ESD, or the International Diabetes Federation. And that value is now expressed in millimoles per mole, but previously was expressed in percentage values. So I again contain both of those. So the first way that you can diagnose it based on the blood glucose values is on a fasting blood glucose. Now that would be 126 milligrams per deciliter or 7 millimoles per mole. And I think in Nigeria, you use the milligrams per deciliter, you would recognize those units. This can be combined with what's called an oral glucose tolerance test, whereby you would fast for at least 8 hours the night before. You'd be asked to come up, have a blood sample, and then you'd be given 75 grams of what's called anhydrous glucose that's dissolved in water. And then you'd have a repeat blood test done 2 hours later. And for the diagnosis of diabetes, either the fasting or the 2-hour value can be positive. It doesn't have to be both. So the fasting value is the same as what I've discussed before, 126 milligrams per deciliter or 7 millimoles per litre. Or the 2-hour value could be more than or equal to 200 milligrams per deciliter, 11.1 millimoles per mole. So this is a very standardized. Now the alternative, so obviously this test is quite complex. It was considered gold standard, but not everybody has easy access to running a test like this, and it is complex with people having to literally give up half a day to come and do it. The alternative, which has become an international standard really over the last 5 to 10 years, is the HbA1c, A1c glycated hemoglobin. That's easy to do because you don't need to fast. You can take the sample. It's a single blood test. So it's quick and easy. People are more likely to do it. And the value for that and the international standards in anybody's guideline is exactly the same, is more than 48 equal to or more than 48 millimoles per litre. And in the old units, that was 6.5%. In terms of the HbA1c, just to put that in context, it's a measure of how much your blood glucose, plasma glucose levels coat your red blood cells, and the value reflects that over the glucose, your red cells exposure to glucose over the previous 3 months. So it involves 2 measures that are combined, which is the glucose with your red blood cells, the hemoglobin level. And then the other way that you can diagnose type 2 diabetes is in somebody who has symptoms of diabetes, which will classically be being thirsty, passing lots of urine, maybe blurred vision, losing lots of weight unexpectedly, would just be a single random blood glucose value that was above the 200 milligrams per deciliter or 11.1. In the dark blue box, I've just put down an explanation for what the abbreviations are, and in red is the reference where this came from, and it's something that you can download for free. So previously, individuals were tested when they had symptoms and presented to a healthcare professional, and that would make sense because you were trying to find out why somebody's unwell. With the increasing awareness of the risk factors associated with diabetes and the knowledge that early diagnosis and even in the pre-diabetes stage, and the fact that people can go into remission, and we say remission, not cure, meant that there is increasing international consensus of the importance of screening individuals who are known to be at a high risk of developing type 2 diabetes. So I apologize because this slide is busy. It comes from the ADA official documents on how to screen and test for type 2 diabetes, but I will go through it. And it is a document that is constantly being updated. It's very similar to UK and European guidelines, and well accepted with some other groups added. So there are 6 groups that are considered, that it should be considered to be screened. The first relates to your weight. So if they consider that you're overweight or obese, and that is expressing what's called BMI, which is body mass index, and it's a way of expressing your weight in relationship to your height. So to be overweight would be a BMI above 25, or to be obese above 30. If you're Asian, whether that's Chinese or Indian Asian, the value is lower, the equivalents are 23 and 28 because of the much higher risk of diabetes in that population. And then you have to have one of these additional risk factors. So a first degree relative with diabetes means your parents, your mother, your father, your brothers or sisters. We know that there are certain ethnic groups that have much higher rates of type 2 diabetes, which includes everybody from the African diaspora. Obviously, this is American orientated, so it says African American, Latinos, the Mexican population, for example, Native Americans, Asian Americans, which they mean Chinese, but that would also encompass Southeast Asian, sort of Indian, and then certain island groups. If you've got a history of cardiovascular disease, which is heart attack or stroke, issues related to high blood pressure, cholesterol abnormalities, women who have a condition called polycystic ovary syndrome, if you're very physically inactive, or you've got there's some rarer conditions that are associated with insulin resistance that should be screened. The other groups that they reckon are people with pre-diabetes, so it's the stage before type 2 diabetes, but they should be tested every year because we know that over 5 years, they have a 50% risk of going on to develop type 2 diabetes. Women who've had gestational diabetes during their pregnancy should be tested every 3 years. Other patients, interesting enough, last year, this recommendation for Americans was to be tested over the age of 45. They've lowered it to the age of 35. And then in the UK, the age for testing is 40. And that's in recognition that we know that people are getting their type 2 diabetes much earlier. If the results are normal, they're essentially saying that because as we get older, our risk of type 2 diabetes increases, that you should continue to be surveilled and checked. They've added a new group, which is people with HIV, which I suspect may be long-term medication related. So it's not the world's most exciting one, but you can understand that the reason that we screen people who don't have any symptoms is that you can make significant interventions and improve their long-term health by intervening early. Because in the past, I would say maybe 30 years ago, if I gave this talk, I would say that many people may have had their type 2 diabetes for up to 10 years before anybody realized they had it, and that they presented with the complications of diabetes at that stage. Whereas we can identify people while they're as fit and healthy as possible and help to avoid them developing those problems, particularly if people are getting it at a younger age. So the next 2 slides that I'm going to talk about are that not all tests are perfect. So I've spoken about the blood glucose, and I'm going to talk about the HbA1c. This applies to whichever guidelines that you use. There's consensus across all of them. And in this is I just downloaded from the UK NICE website. If you just focus on the 2 boxes I've highlighted in blue. So all of them agree, and if you look on to my left, that if a person is symptomatic, a single blood test is all that's required, whether it's the glucose or the HbA1c, to confirm the diagnosis. If you look on the right panel that's highlighted, all of them also agree that if somebody has no symptoms, so i.e. they have a result that comes back positive when they're being screened, you have to do a repeat. And that's to ensure that there just isn't a technical issue why they've got an abnormal result. You should stick to the same test that you did, whether it's an HbA1c or glucose value. and ideally to do it within a short time frame. They do comment that if people have the second test is normal, which with the H1C could happen if there was a few months between the values and the person made lifestyle change, you should continue to monitor them because they may deteriorate. Now, in this one, the HbA1c, as I mentioned, it reflects both your red blood cells as well as your glucose and how the two interact with each other. So if you have a problem with your red cells, so firstly, there are some groups that you shouldn't use the HbA1c to interpret for diabetes. And essentially, this is people that are either too young or have a condition that may cause a temporary increase in their blood glucoses, which would be gestational diabetes, or again, not for 2 months after they've delivered because they'd be anemic. If they've had their symptoms for a short duration, because I said the H1C reflects your sugars for 3 months. So you have to have had your diabetes for a significant period of time for it to be affected. We know that sometimes if you are very severely ill, say, for example, you've had a heart attack, major sickness, your blood sugars may raise temporarily and then actually go back to normal within a 2 to 3 week window. So you need to take that factor into account and reassess somebody. And also some medications can make your blood sugars go up. The most that's well known is steroids and some antipsychotic drugs for people who may have some mental health issues, for example. If you damage your pancreas that include the insulin producing cells, that causes a different type of diabetes. And for people who they talk about with end-stage kidney disease, your kidneys help make your red blood cells and they're often too low, you're very anemic, and so the result will not be accurate. The other side of that is that if you have an abnormality in your red blood cells or how the rate that they turn over, because you're constantly making new ones and old ones are dying, that will cause the result not to be accurate. In the Black community, that may show itself, for example, if the shape of your hemoglobin is abnormal, so that's sickle cell trait, sickle cell anemia, and there's another condition called thalassemia. And that may affect the HbA1c results. Certainly, I know with the sickle cell trait, there are blood assays that can take that into account and still give accurate HbA1c results. We have that at King's because we have a large African Caribbean ethnic community. So that was an important thing when we were designing our system. If you have any form of severe anemia for any reason, that will give an inaccurate result because you just don't have the red cells, or if they get destroyed and turned over too quickly, that will also give an abnormal result. So you do have to be aware of some of these other caveats about why people may not have an accurate result with HbA1c. So having spoken about that, I'm just going to briefly show you 2 risk factor assessments because I've spoken through what the risk factors are. This is one from the ADA. It's very easy to download, and I've provided some web addresses later. And it means you can easily assess yourself. It's based on the aspect I talked about, which is your age, your gender, if you've had gestational diabetes, a first-degree relative, high blood pressure, how active you are, and where your weight is. That's what the table is over this side here, gives you your height and which weight range in pounds that you're in. If your score is more than 5, that would say that you're increased risk, and they would advise you to check with a healthcare professional. This is an alternative one from the Diabetes UK, so UK risk stratification score. It includes an additional factor. It's similar to the American one, but it does also include your waist measurement. And the reason for that is that we know if you tend to put your waist on around your middle, rather than your hips and your thighs, you are at increased risk of diabetes. We call them apples and pears. So apples are rounded tummy, pears are sort of, heavier on the hips and thighs for weight. The advantage of this one and why I like it is it stratifies your risk when you go through the score. And so it can tell you a little bit more accurately what your 10-year risk is. On the DUK website, over 2 million people have done this, and it's free to access and you can assess yourself. So low risk will give you a 10-year risk of 1 in 100, that's 1%, versus high, which is 1 in 4, that's a 25% risk over the next 10 years of developing type 2 diabetes. And certainly in England, it would say if you were moderate or high risk that you should go to your GP practice for a health check. So I'm going to just go over this one. So as I said before, there are some things that you can't change in your risk score. You can't change what your age is, your gender, your ethnic background, or if you've got a first-degree relative with diabetes. But what you can change, and which a lot of lifestyle prevention programs are aiming at, is your waist measurement, your BMI, and your blood pressure. Now, this is me. I'm now a year older, so I'm still in the 5 points for that, but next year I shall be in the 60 to 69 age group, and my score will go up by 4 just because of my age. I'll cope with that. But the reason we have these risk scores is that we know with big lifestyle interventions that actually I call being a healthier version of yourself around healthy eating and activity, you can decrease your risk. You can affect those 3 values that can change. These are some useful web links because I'm conscious of time and people may have some questions they want to ask me. They're all free. They're to reliable websites. They have lots of information for people who would be concerned that at risk of diabetes or already have type 2 diabetes. The app that I thought for healthcare professionals was very useful was the ADA Standards of Care. They update it in real time, and you can get that off of Apple or Google Play, and there's also a web version. And then the International Diabetes Federation, which is a conglomerate of about, I think it's over 70 countries, of which Nigeria is a member, is an advocacy group for people with type 2 diabetes, which I think is very helpful. So in summary, there's several ways to diagnose type 2 diabetes. Accuracy is important, and we do all need to be aware of factors that may affect the accuracy of those results. There's an increasing recognition of the importance of screening to identify high-risk individuals and to intervene early, both at the pre-diabetes and type 2 stage, to minimise the risk of complications of diabetes in the long term, and to support possible remission of both pre-diabetes and diabetes. So thank you very much for listening to me, and if you have any questions.
Thank you, Dr. Gale. If you have any questions, I did ask to post them in the chat, but if you have any questions now, just raise your hand so I can find you and ask you to unmute. We have a question in the chat. Please, could you explain HbA1c one more time?
Okay.
Stop sharing the screen for me, please.
Yeah, no problems. Let me just stop sharing the screen. Hang on, it's not, hang on, let me see if I can just stop viewership. I've gone to the button, Flora, but it's not, hang on, pause share. It's a different button just to confuse me. No, stop share. Okay, is that better?
Yes, thanks. So,
okay, to explain HbA1c. So, if you think about it, your red blood cells and your plasma glucose or blood glucose circulate together. And the way to think about it is any given red cell gets exposed to a certain amount of glucose and it sticks to the red cell surface. And HbA1c is a measure of how much glucose is sticking to the surface of your red cells. So when you have diabetes and your sugar's higher, if your red cells are behaving normally, you will have more glucose sticking to the surface, and therefore you get this higher value HbA1c value. So that's what it reflects. So there's 2 things that can affect it, the glucose, the amount, but also whether your red cells are functioning normal. So if you're anemic, it means your red cells are very low. There could be many reasons for that. Then therefore the red cells aren't there to be coated by the glucose. It will give you a false low result. So if people have disorders of their blood for any reason, you cannot use the glycated hemoglobin value at that time to diagnose diabetes because it may not be accurate.
Okay, great. Okay, now sugar, the effect of sugar. You mean know what I'm going to say? Yes.
Well, for people with diabetes, type 2 diabetes, so if we're talking about eating sugar or things that get turned into simple sugars, because I think everyone knows an obvious sugar like sugar, honey, sweets, crisps, chocolates. Everybody knows that's obvious sugar.
Well, with the honey, people say I don't eat sugar, but I use honey. So we'll talk about that as well.
Honey has got some healthy things in it, But in your body, it gets metabolized to sugar, and you can't tell it from chocolate sugar or any other sugar. So the problem is it's not a good substitute because it gets absorbed just as quickly and broken down just as quickly. The sugars that people get may not always be aware of is what they call the starchy carbohydrates. So that would be bread, potatoes, cassava, yam, rice. Those types of starchy and yam, starchy carbohydrates, they get broken down almost as quickly as ordinary sugars. And for people with pre-diabetes or type 2 diabetes, your body just doesn't, so all those get broken down very quickly. They can make your blood sugars go up very quickly. When you've moved into the diabetes stage, the problem is that your body cannot put out enough insulin to bring the sugar down quickly enough. That's why we talk about eating modest amounts of carbohydrates. I'm not saying you should never eat those carbohydrates, but you need to have moderate amounts of them so that when they're absorbed, your body has a bit more time to make extra insulin to deal with it. Because the problem with people with diabetes, pre-diabetes and type 2 diabetes is actually in the early stages, you make more insulin than everybody else. It's your tissues are resistant to it and don't respond very well. So it's not that you can't make the insulin in the early stages, it's your body, your tissues just don't respond to it. So you've got to therefore think about it as I need to introduce the carbohydrates in a small amount and so that it can be absorbed more slowly so my body can try to compensate for the fact that my tissues don't respond very well to the insulin I make.
Okay, thank you for that. Someone's asked, what is the effect of stevia for diabetics?
So stevia is one of the newer artificial sugar substitutes. It does not make your sugars go up, and out of all the artificial, if I use the word sugars because they're not really sugars but they have the taste, it comes down to trying them and deciding which one you like the taste of. Okay. There is, so stevia, if I remember rightly, is the plant-based one, and I know I've tried it. And I'm trying to remember the other one. In England, it comes in a yellow package. I do apologise. There is only one of them that you can use to cook with. The others, if you heat them, degrade, and you can't sort of cook with them if you wanted to. And that's because everybody's going to make cake or something sometimes. But there is one version of it. It will come back to me and I'll remember that you can substitute some of the ordinary sugar. You still get the taste and the texture, but you don't get as much sugar in the food when you're eating it because you substituted some of the sugars. Okay. Splenda is what it's called in England, but I'm trying to remember what was the proper name. So you can substitute some Splenda in for sugar if you say we're baking a cake, and it would at least make it a little bit healthier.
Great, thank you. Dr. Agon, you wanted to make a comment?
Yeah, it's called sucralose.
Thank you.
That's the one.
Right.
Is it sucralose?
Yeah, and certainly in England, a lot of the supermarkets sell their own brand version, which is half the price of the original one, which is called Splenda. But with all the artificial sugars, it comes down to trying them, you know, and seeing if there's one that you're happy as a substitute, because they do taste different. And, you know, they have a different kind of sweetness, and it's which one you prefer. So for me, I've tried them all. I try them all so I can give patients feedback about them. I don't like any of them. So I don't have the sugar and I don't have those.
All right, great. Wow, that's good. Tunji Ahmed, you had a few questions. Do you want to unmute and ask your questions, please? Tunji Ahmed?
Yeah, yes, please. Thank you very much for very detailed and comprehensive presentation. You are talking about sugar cane. What is the risk if you don't take the normal sugar and you take sugar cane? Again, what about or some other source of the other food that has some other source of sugar? Then I want to also, please, if you can go through the science of diabetes too. Thank you very much.
Okay, so this is the the bit that people may not want to hear. It doesn't matter whether you eat. The only reason sugar cane is better than sugar is you've got to chew the cane. All right. But once that sugar cane has been processed and put in a bag that you buy in the supermarket, whether it's white, caster, light brown, dark brown, molasses, maybe the molasses just, but even with that, once you've eaten them, they get metabolized really quickly to glucose and they hit your bloodstream really fast. The best way I can describe it, say, and even like fruit sugars. The reason we say, for example, don't drink juice is that a glass of orange juice, a standard glass, I don't know if you can see me, but this is, I can't show, it's not coming across, right? That's the standard glass of orange of water for me. That glass, I'm sorry, it's not showing very well. That would take maybe 7 to 10 oranges to fill a large glass to make it. I always say to people, how quickly could you drink that glass of juice if you were thirsty? And the answer is very quickly, probably less than a minute. If I gave you 7 oranges to eat, what is the chance you're going to eat them? Not likely for most people. And even if you did, you would have to cut them up, you'd have to peel them, you have to chew them. So both of them will give you a large, I'm not saying that orange juice is not it is healthier than sugar because you've got vitamins in it, but ultimately the sugar is the same and it gets into, if you have it as liquid as juice, it gets into your body really quickly. It is far better, we always say, to eat the fruit, to peel and chew an orange, because you'll probably be satisfied with 1, 2 at the most, whereas juice you can just consume huge amounts of oranges very quickly. So that's, so I'm afraid sugar is sugar and it's not that healthy. It does, you know, yes, you could say the brown ones has some other things in it, different tastes, maybe a little bit healthier, but once it hits your system, it's a quick glucose sugar surge. I think you were asking, I'm sorry about your second question.
Signs and symptoms of diabetes.
So I think you asked about the other carbohydrates that turn into sugars in the blood, and that is things like potato, rice, yams. In Jamaica, they'd have something called ochi, rice, bread. All of those things will break down into sugar fairly quickly. So we're not saying don't have them. If you have a simple plate model, we would say they shouldn't be more of a third of a plate, and that's if you mix up different ones. Still no more than a third of the plate, and I always tell my clients not piled high, because they create themselves like a little pyramid. And I say no. And then a third should be vegetables, and a third should be, if you eat meat or fish, meat, fish, your protein sources. So the science of diabetes, I suspect I haven't got, so for type 2 diabetes, the problem is your tissues are resistant to insulin. And normally you eat, your body makes insulin so that the glucose that's in your blood circulation gets taken up by your tissues so that you can use it for energy. People with type 2 diabetes, you make often extra insulin to try to overcome that resistance at the tissues. And that's why activity is so important, because that helps upregulate the receptors on the tissues and your muscles and take up the glucose better. And that's why all the lifestyle prevention programs work, because of activity makes your body respond better to your insulin. I hope that kind of covers it.
Thank you. So sugar is sugar.
Yeah, you can wrap it up, but it's sugar.
Yes. All right. Next question from Joe. Please unmute yourself and ask.
Okay. Good afternoon.
Hi.
My name actually is Julius.
Okay, you've got Joe on your screen, so that's why I won't buy. I'd like to ask thank you for the fantastic presentation. It was very insightful. I don't know if it is appropriate to ask this question right now, but I'd like to know, what are the likely what are the implications for the long-term use for metformin, which is a common drug for type 2 diabetes?
Okay, so this one I have a lovely clear answer. It is protective. So metformin works by making your tissues more sensitive to the insulin that you make. So that's why it's often our first line. it's very unlikely to make your blood sugars go too low, and it's weight neutral. Some people it helps them to lose weight, but for most people it's weight neutral. So that's how it works. And interestingly enough, there was a very big study that followed up 10,000 people, 5,000 each arm, people with newly diagnosed type 2 diabetes. They followed them up for over 20 years. And actually, in the long term, metformin also gives you cardiovascular protection and decreases your risk of a heart attack.
All right, Joe, I hope that's answered your question. All right, last question before we go to the next speaker. Any other questions we'll take at the end? Jimmy? Any other? Jimmy, could you unmute and ask your question? All right, AA, this is the last question. Any other questions you have, pop them in the chat. We'll take them at the end. So last question. Thank you. Go on. Jimmy, we can't hear you.
Yeah. Yes.
All right.
For the I have been managing diabetes.
All right, Jimmy, I think it's best for you to post your question in the chat because your line is very bad.
7 years. Currently, I've been predominantly.
Jimmy, please post your question in the chat. We're going to move on to the next speaker because of time. AA and Fumi, please put your questions in the chat and then we'll take it at the end. Apologies for that, but we do need to move on. All right, thank you, Dr. Carol. So now, I can hear some background noise. Can everybody please mute themselves? Please ensure you're muted. Thank you very much. Okay. All righty. So our next speaker is Professor Olufemi Fasamade, and he will be talking to us about treatment. Professor Fasamade is a consultant endocrinologist and is the unit head of endocrinology, diabetes, and metabolism division in Lagos University Teaching Hospital, also known as LUTH. He's just completed a 4-year tenure as the chairman, Medical Advisory Committee of LUTH. Professor Fasamade, over to you.
Thank you very much, Flora, and the organizers of this wonderful symposium. I will be talking after the very clear lecture given by my colleague, Dr. Carol Gale. I'll be going to the next part, which will be talking a little bit about the treatment of diabetes, which some people have already started asking questions about. I work in the Lagos University Teaching Hospital and the University of Lagos. I am a consultant endocrinologist and I'm a lecturer. So I will just share my screen now so we can go right into the talk. So, okay. So we'll be talking about the treatment of diabetes mellitus, and I'm taking this on the beautiful foundation by my previous colleague. And this is the brief outline which I'll be taking, and that includes the talking about the lifestyle, the medications, and things like surgery, which I'm sure people will be quite eager to hear about. That what does surgery have to do, or can you get a cure for diabetes through surgery? So when we talk about lifestyle, usually quite a number of our clients don't like to listen to this part. They just want to leave the consulting room and say, doctor, just prescribe a medication. But the first part of your treatment is to change your lifestyle, because diabetes, hypertension, and very many medical conditions are lifestyle diseases or degenerative conditions. And when we are talking about lifestyle, we are talking about the things that predispose you to developing diabetes in the first instance. So it is a very vital part of the diabetes treatment, and to some extent, it will help to reverse the downward trend that diabetes tends to cause. It involves stopping unhealthy habits. There are some habits that we indulge in that push us into diabetes. And if you can stop these habits, you are also halfway out of the problems that diabetes brings. And these unhealthy habits include things like smoking, whether it's smoking a pipe or smoking a cigar or smoking anything. Smoking is generally bad. Eating fast foods, which many people indulge in either because they are rushing to work or rushing back from work. So they take their breakfasts in the car, maybe they buy some meat pies or sausage rolls on the way, and coming back, they do the same thing. So eating fast foods is not good. Also, drinking alcohol is not to be encouraged. We advise people, please stop alcohol or reduce it drastically. And then taking carbonated soft drinks, no matter the beautiful name they come by, or the beautiful colors that they are decked in, or how attractive they look to the eye. All carbonated soft drinks are unhealthy. And when we talk about lifestyle, we're also talking about imbibing healthy habits. And these healthy habits include exercise, eating healthy food, fruits, vegetables, nuts, and cereals. When we talk about being active in your lifestyle, because it's easy to be active, someone told me that does staying in the fuel queue and waiting for 2 to 3 hours to get fuel, does that constitute activity? And I said, no. Another person also asked me once that if he's giving back-to-back lectures and he's sitting down, isn't that being active? Again, that is no. When we talk about being active, we're talking about a 30 to 45-minute brisk walk daily. In place of walking, you may also cycle, or you may swim, or play tennis, whether it's table tennis or lawn tennis. If you could do this 30 to 45 minutes daily, then you are an active person. Staying in your shop and attending to 100 customers is not active. Staying in the consulting room, seeing 20 clients a day is not active. Also, 8 to 10,000 steps daily is being active. The lower number is for the elderly, but for the younger people who want to keep diabetes away or bring their blood sugars within control, we normally recommend 10,000 steps daily, which is about 4 to 5 kilometers per day. We ask people to use the stairs and not the elevator. So whether your office is on the 3rd floor or 4th floor, use the stairs. It may take you a while longer, but it's a healthy habit. In the same vein, also make sure that you are not a couch potato using your remote control for everything. Sorry, let me go back. Make sure that you move, and wear appropriate shoes. If you are overweight or if you are obese, then you should join a nearby gym, and you should exercise with a group of family or friends, because if you are doing it alone, it's not so much fun. Watch your diet, count your calories, and if you know you are overweight by your BMI, which Carol explained earlier, try to lose 7 to 10% of your body weight in a year. And the first step in doing that is to know where you are now. How much do you weigh? Many people don't even know their current weight, and they don't know their ideal weight either. So you must know your current weight, you must know your ideal weight, and you must strive to move closer to the ideal weight. As I said earlier, junk food or fast food, they are not good. Why are they not good? They have plenty of salt, sugar, and fat, and they have very little fiber, very little vitamins. And so generally, they are not to be consumed if you have diabetes or you want to prevent diabetes. eat a sit-in meal in your house with your family. And if you're going to work, pack your food along. Do not eat junk food. Then you will say, what is healthy food? The bowl that you are looking at on the right of the screen is a healthy plate of food, plenty of colors. And this healthy food includes vegetables such as greens, cabbages, spinach, lettuce, tete, shoko, ugu, or nuts, peanuts, cashew nuts, walnuts, pistachio nuts, almonds. All nuts are good. And then fruits, using a variety of colorful fruits, as you can see in the slide, and then minimal processing. So don't go blending these meals or making juices or smoothies out of them. So what medications do we use if we have been told we have diabetes? There are various medications. The main groups of the medications are injectables and oral glucose lowering agents. I won't go into the specifics of the names because I don't want you to just go to the pharmacy and start shopping for the medications. But there are different types of insulins, different types of insulin analogs, and then some other injectables called GLP-1 receptor agonists. For the oral lowering agents, I think the previous speaker mentioned one of them, and that's the commonest one for almost all patients, which is metformin. It belongs to the group called the biguanides, but there are many other oral agents, about 10 different groups of drugs, but the most commonly used are the biguanides and the sulfonylureas, which include glibenclamide, glimepiride, gliclazide. So there are many medications that your doctor will choose with your active participation. So what's so special about these oral agents? Well, there are many groups of them, and the doctors usually will choose one from each group. If your blood sugars are not too high, it might just be one set from one group, such as metformin. But sometimes if your blood sugars are quite high or your HbA1c is very high, you might need to take one medication from 2 or 3 groups of medications. And some people have to take these once a day, twice a day, or 3 times a day, depending on the type of medication you are taking. The medications are combined according to response. So you might start with one group, move to 2, move to 3, or you might be on both oral and injectables together. The other thing you need to know is for the anti-diabetic drugs, for the injections, there are several types. Even for the insulins, there are different types, short-acting, long-acting. Then there are some that look like insulin but are not insulin. We call them the insulin analogs. These also have short-acting, they have long-acting. And then we have the GLP-1 receptor agonists. We have pramlintide, which is available in some countries, not available in Nigeria, and a few other injectable anti-diabetic drugs. Most of them are given with a needle and a syringe, or they may come in pens, which can be easily administered. How do we take the medications? They must be taken regularly, which means please follow your doctor's prescription. There is nothing like, I'm tired of taking the medication, I want to stop. There is no stopping and there is no break period, except the doctor tells you to stop for a particular reason. And please don't combine herbal or native treatment with the one given to you. Don't borrow your friend's medications, because some people say, I ran out of mine, so I went to my neighbor, he also has diabetes, and I took his medications. They may be different, the doses may differ, and you may have different types of diabetes. Also, make sure you have enough stock of your medications at home, because you never can tell when there will be full scarcity, you never can tell where there will be some insurgency, or if you're in some parts of Europe, there could even be war. So make sure you have your medication and have enough before you exhaust the previous supply. Don't wait till the last tablet is over. Make sure you take your tablets with water, not with tea, juice, alcohol, or honey, because some of them might have some interactions with what you're using. Injections are usually to be taken before food and at the same time daily. So if your injections are to be taken in the morning, make sure that the time is the same every day. There are a very few number of patients who may have surgery as part of their treatment for their diabetes. For instance, those who weigh more than 120 kilograms, which would be about 250, 260 pounds. Some of them may have, they may be referred to the surgeon who might want to do some surgery on the stomach to help to lose weight and to lead to some degree of remission or temporary or permanent cure of diabetes. It is usually a temporary treatment or a remission for a short period of time. For those who allow their weights to go back up after having that type of surgery, diabetes also still comes back up. These surgeries are called metabolic or bariatric surgery. They include gastric sleeves and bypass surgery. And if you are very, very obese, this might be for you. In other patients, the pancreas can be transplanted. For instance, a person who has chronic kidney disease or end-stage kidney disease who needs to have a pancreas transplant, a kidney transplant. Sometimes this is combined with a pancreatic transplant. But again, it's not as if the diabetes has been cured. You have remission or you have reduction in the number of medications you need to use in most of these patients. In summary, diabetes is a complex medical condition. It requires a combination of diet, exercise, lifestyle changes, along with your tablets or your injections. And remember that the treatment is lifelong. It should not be combined with native medicine, Chinese medicine, Indian medicine, or any other type of medication. Remember that to most patients, to 99% of the patients, there is no cure. But in the few that are super obese and have bariatric surgery, some of them might experience a reversal of the diabetes or a temporary or a permanent cure if the weight loss that these surgeries bring about is persistent. In a very few patients, pancreatic transplant or islet cell transplant may offer a cure, but usually these are in experimental conditions or in a few studies or trials. Thank you very much for your attention. I'll be willing to take questions on my presentation.
Thank you very much, Prof. Are there any questions? Please raise your hand while I'm waiting for that. Prof, could you talk about the complications of diabetes, please?
Yes, diabetes has many complications. I was seeing a client a few hours ago and he was asking which complications can I have from diabetes? And I told him that you can have complications in every single organ. Diabetes is about the third commonest cause of blindness. Diabetes is about the second commonest factor leading to strokes and hypertension. Diabetes is the commonest cause of non-traumatic lower limb amputation. In Nigeria, diabetes is the commonest cause of end-stage renal disease. Diabetes is the commonest cause of premature loss of the teeth. It's the commonest cause of fetal wastage, meaning recurrent miscarriages. So diabetes affects every single organ. It causes neuropathy, retinopathy, angiopathy. It causes gastropathy, cystopathy. All these pathies just means abnormalities in the bladder, in the kidney, in the stomach, in the nerves, in the vessels, in the eyes, in the mouth, in the skin. So diabetes causes a lot of complications. But these complications need not to affect you if you are listening and you have diabetes, if you are able to keep your blood sugars within the recommended target ranges. as Dr. Gale had projected earlier. She had told us where the target blood sugars of every person should be.
Okay, there's something that some people may have come across called diabetic foot. What is that?
Yes, diabetic foot, well, that is the old name we used to call it. Scientifically, we usually now call it diabetes mellitus foot syndrome. And that just means a sore or gangrene or decay of any part of the foot below the ankle. So if you do have a sore on your foot, on the top of your foot, on your toes, any part of the foot, usually they do not heal very well in a person that has diabetes. And it might just start from a very small boil or abscess or from a small blister and involve the whole foot within a few days, in which case the foot can become very foul smelling, very swollen, and then discharging a lot of pus or blood. And if you allow that to happen, this can be life-threatening, and it is in a bid to save the lives of people that have that complication that the doctors often offer an emergency amputation of the whole leg affected. So that is why we also advise people that have diabetes, please make sure you pay particular attention to your feet. Inspect your feet immediately you wake up. Inspect your feet before you go to bed. Check in between your toes. Use a mirror to look at the sole of your foot. Make sure there is no discoloration. Make sure there is no sore. Make sure there is no rash. Make sure that there is no boil. Make sure that you have not injured your foot inadvertently. And also inspect inside your shoes before sticking your feet inside them.
Thank you so much, Prof. I think our podiatrist will be doing a demonstration for us later on how to check your feet. Thank you. Fumi, you have a question? Unmute yourself, please. Fumi, I or L? You had your hand raised?
Yes.
Okay, go ahead.
Thank you very much for this. I wanted to ask about the lifestyle change. So say I've changed the lifestyle, eating healthily and exercising. And you mentioned something about weight loss. So if I've been trying to lose weight and nothing is happening, and I think a few people may have the same issue. If you're petite, your BMI sort of is always out of range because they do the maths with your height. So is there any other options to be able to lose weight? I know the endocrinologists have said something about, in addition to metformin, to take semaglutide injection to help to lose weight. Is it something that I can look into? And also, you mentioned boils. Is boil a sign of having diabetes, or what does that mean? Thank you.
Okay, so for weight loss, often quite a number of people make the error of thinking that you could just modify your diet and the weight will melt away. And when people have tried this over and over again, people just tend to give up. They say, well, maybe these doctors don't know what they're saying. I've tried all the diets. I take vegetables twice a day, 3 times a day. I exercise. Weight is another disease. Being obese is a disease on its own that also needs to be managed the same way we manage diabetes. And what do I mean by this? To manage a person's weight is a multidisciplinary task, meaning that there are different specialists that are involved. The same way managing diabetes has different specialists. To manage your weight properly, you can't do it alone. The person with diabetes needs to consult a dietitian or a nutritionist. He needs to see a physical therapist. He needs to see his endocrinologist. And sometimes he might even need to see a surgeon. And in addition to lifestyle, in addition to exercise, very often, if you want to successfully lose sufficient amount of weight, you might need to add some medications, one of which you have mentioned, semaglutide, liraglutide, orlistat, and several others. And even depending only on the medication does not succeed. You need to do all these things I listed simultaneously. Diet, exercise, medication, gym, see your nutritionist, sometimes even see your psychologist, and in some extreme situations, see the general surgeon. If all of these are combined in the appropriate amount, then most people will have significant weight loss. However, please note that if you are weighing like 100 kilograms, we don't want you to get to 50 kilograms. That is not successful weight loss, and that is not sustainable. We are talking about just 7 to 10% weight loss. So if you are weighing 100, if you lose 10 kg, you have successfully lost a lot of weight. But if you still want to go down further, just losing 7 to 10% of your body weight per year is a manageable and sustainable weight loss that any person with diabetes can resort to.
Thank you, Prof. Scholastica, you had a couple of questions. I will take those before we move on. We'll deal with the rest of the questions at the end. Scholastica, do you want to put your hand up so I can find you, for you to unmute yourself, and then you can ask your questions? Scholastica Davis? If not, I'll take another question. No? Okay. So, Scholastica was asking in the chat about... Okay, let me go to AA. AA, go ahead.
Hello, good afternoon. Thank you for having me. I just wanted to ask, my husband is recently diagnosed with type 2 diabetes, and he takes the metformin, but he's usually tired after taking it, and he usually doesn't want to eat because he says he's got loss of appetite, and he's lost the sense of taste due to the medication. He said the doctor told him that, yes, you would have that symptom. So is that normal? And then does he need to be taking like vitamin B supplement with the metformin? And the second thing is there's this medication I normally get from Nigeria that he's been using even before he got the diagnosis. It's called Celgivity. I know a family that sells it, and she said it's good. But now you're saying the doctor that just spoke said they shouldn't combine their normal medicine with herbal medicine. So how do we balance all that? Thank you.
Okay, thank you very much, AA. The answer for the first question is people that do take metformin, the reason why it's the most popular medication for diabetes is because it does not cause hypoglycemia. It does not lead to low blood sugar. That is one. The second reason why it is very popular and most doctors will prescribe it first is because it does what you mentioned. It reduces appetite, and it also leads to weight loss in quite a number of patients who are on it. So those are the positive points with metformin. But for some people, the loss of appetite or the metallic taste in the mouth is so bad that they can't eat at all. If you are weighing about 140 kilograms or 130, and you consulted me that you don't have appetite or the drug is not making you eat, I'll be very happy. I will not want to give you any appetite stimulant because I want you to lose weight. So if your husband is obese, I think he should just continue to use the medication because if you start taking B complex or anything to stimulate the appetite, cyproheptadine and so on, you've already lost the advantage of taking that metformin. But for those who the taste in the mouth is so terrible and they cannot tolerate it, or they are nauseous, or they are vomiting, please speak to your doctor. It's likely to reduce the dosage or replace the medication. The second question you asked was
about herbal medicines.
I think it was Celgivity or something. Yes, you are talking about, yes. Celgivity is a popular medication used, I'm sure, in Nigeria and other places. And some people think it's a magic wand. There are so many medications like this. They are quite expensive, but I tell people they are just supplements. They do not treat diabetes. So whether it is GNLD, whether it is forever living products, whether it is longevity, whatever medication these ones are, most of them are just supplements. And if the cost of your supplement is more expensive than the cost of your medication, it means your priorities are a little bit misplaced, because you find that quite a number of these supplements are so expensive, and some people with diabetes actually think because they are very expensive and they are more expensive than their metformin and other drugs, then those must be the drugs to take. And they run out of the regular anti-diabetes medication and major on the minor. So please, longevity is not a treatment for diabetes.
Thank you. So as you were speaking, the hands were flying up. Okay, let's go to Joe first. Joe, unmute yourself, please.
Thank you very much, Prof. Thank you very much for your presentation. I would like to know if diabetes or the drug metformin has implications for sleep. I usually wake up around 3 a.m., sometimes 2 a.m. regularly, and I find it difficult to sleep after that. I don't know if it is a drug or maybe it is diabetes. So I'd like to know your advice on that, your opinion on that.
Thank you very much, Joe. If a person is waking up by 2 a.m., 3 a.m., a person with diabetes, and you find it difficult to sleep, one thing you could do is to check what your blood sugar is at that time. It might be that you have hypoglycemia, which will make your heart start to race, will make you start sweating, and make you uncomfortable or have bad dreams or unable to sleep. So please check your blood sugar around 2 to 3 a.m. on those days that it happens. It's not likely to be due to any of the medications per se. It's probably due to your blood sugars dropping. So it means you may have to adjust the time you take the medications, or take a slice of bread or an apple or an orange last thing before you go to bed, so that your sugar doesn't drop very much at 2 a.m.
Great. Okay, Linda, unmute and ask your questions. Just 2 more questions and then we'll move on. Linda?
Thank you very much, Prof. I've been diagnosed since I was 17, and each time I go to a different doctor, it is either I'm told I am type 1, another one will tell me I'm type 2. I have changed from metformin to insulin alone to glimepiride. Now I want to know, how do you know what type of diabetes you have? And presently, I am going through a lot of hypoglycemia symptoms, especially at night, because I changed from metformin totally to Humulin, because according to the doctor, I was underweight. Like I was weighing 57, and I'm 35 years of age. So he was complaining my weight is very, and I wasn't eating well. So I really want to know, how do you know if you're type 1 or type 2? Thank you, sir.
Thank you. There are some ways to know you are type 1 or type 2 in terms of probability. For instance, if your diabetes is diagnosed when you are very, very young, maybe 12, 13, 14, 15, 17, and tablets were tried and they didn't work, most likely that person has type 1 diabetes. But if at any time you are able to use tablets for a long period of time, maybe you're on tablets alone without insulin for 1-2 years, and you are still alive, then it means most likely you have type 2. I said most likely. In terms of definitive diagnosis, you need to go to the laboratory to do a test called C-peptide assay. And then you also need to do some other more complex tests, which are called anti-GAD antibodies, to know whether you have type 1 or type 2 diabetes. Type 1 diabetes used to be called insulin-dependent diabetes, which means a typical person with type 1 diabetes is almost always dependent on insulin for his day-to-day existence. while type 2 used to be called non-insulin dependent because quite a number of people that have type 2 diabetes can be on only diet. Some can be on diet and tablets. And that's why it used to be called that way. But the reason why those old names were removed is because there are a few patients who have type 2 diabetes who require insulin every day. So that used to cause some confusion. And then there are some people that have type 1 diabetes who have what we call a honeymoon period, meaning a 2 to 3 month period when they don't need any insulin and they feel they are cured. Some even go to give their testimonies in their worship places that the diabetes has suddenly disappeared. But this is called the honeymoon period. So listening to your history, I think you might be type 2 diabetes because you said you've been using tablets and they've controlled you fairly well enough. In terms of your weight, a person who is underweight, usually such people are placed on insulin or sulfonylureas. If your BMI is less than 20, it is unlikely that the doctor will put you on metformin because they're going to lose more weight. Usually, such people with low weights or low BMIs are on a sulfonylurea or they're on insulin because insulin is weight gaining. So try to consult your doctor. If he's not an endocrinologist or a diabetologist, try to seek an appointment with one and then table your fears before them.
Thank you. So last question, Abimbola. Please unmute yourself.
Good evening. Thank you for this great presentation. My question is, do heavyweight babies predispose you to diabetes? And I'll back that question with my experience. The heaviest I've weighed in my lifetime has been 58 or 60. My first baby was weighing 5 kg, and with the baby, I was weighing 45. My second baby was weighing 4.6, and then my third baby was 4.4. And I remember the question that I was always asked each time was, are you diabetic? And then, they would run the test and, there was nothing. And boom, just recently I was diagnosed. So I've been on metformin, but I just thought all those times there was no indication, there was nothing. So is that related? Although I must add that I recently found out that it's hereditary. My brother has it now, and I found out that my dad, that he passed, and that was what he had. I didn't have this information until recently. So I'm thinking that might be part of it. However, do you think having heavy babies could predispose you?
Yes, thank you very much for your question. Any woman that has a baby greater than 4 kilograms, usually it means that person most likely had gestational diabetes. It is usually asymptomatic. So if you didn't do an OGTT in pregnancy, you won't know that you have it. So any lady who has had babies weighing greater than 4 kg had diabetes in that pregnancy, gestational diabetes. And if we're asking histories from patients, usually those are some of the questions we do ask. Do you have a big baby? And if the person says yes, then in our mind, this person is at risk for diabetes, because a person with gestational diabetes or pregnancy-induced diabetes is at 2 to 3 times higher risk of developing diabetes in the future. So most likely you had gestational diabetes that was not recognized or not diagnosed, and that's why those babies were big. Also, the big babies too have their own risk of diabetes in future. So please watch over your children, let them live healthy lives, because they too have a much higher risk of developing diabetes, especially since it's also common in the family. So big babies, yes, that is an indicator of future diabetes, just as you have experienced.
Thank you, Prof. That was great. We will move on to the next speaker. If you have any more questions for Prof, he will take them at the end. Just pop them in the chat so you don't forget when it's time for us to do that. Okay, we talked about diabetic foot earlier on, And our next speaker is Oluwakemi Ojo. She's a podiatrist, and once she qualified, after a year of working in the National Health Service, she took an interest in diabetic foot, which is what she specializes in at the moment. So, Kemi, over to you. Tell us what podiatry is all about.
All right, thank you, Flora, for having me. And good day to you, everyone. My name is Kemi Ojo, and today I'll be talking to you about podiatry and how to train in the UK. I believe it's a different training in the US, and currently there is no university in Nigeria offering the course. So I train here in the UK, so I'll be telling you how you can train in the UK. So let me share my screen. So bear with me. Okay, so what is podiatry? Podiatry is a branch of medicine. So we diagnose, treat the disorder of the foot and ankle and the lower extremities. And probably you might have heard of the word chiropody and podiatry. Chiropody is an old term, used for practitioners that specialize in foot and ankle. And podiatry is the new word now, and is generally used across our countries and worldwide. So what is the role of a podiatrist? I think there is this general assumption that podiatrists were nail cutters. We do that, we do cut nails, but we do far, far more than that. As a podiatrist, we improve the mobility of our patients, we add to the quality of life, and we improve it as well. And we keep them independent, we keep them maintaining their health by exercising, and keep them in employment and making a life living for their family as well. So as a podiatrist, we offer preventative care, whether to our diabetic patients or even to the general public, even if you don't have diabetes, or if you have some disorder of the foot and ankle, we offer treatments for that. For example, in our diabetic patients, it could be as simple as just managing their toenails to prevent them from having ingrowing toenails, because this can further deteriorate and lead to infection. And if your diabetes is not well controlled, the infection can get much worse and just spread into your foot, into your leg, and before you know it, it's time for the leg to come off. So as simple as cutting toenails or just taking down the hard skin. So we do all that as well. Okay, so in general, we look at the foot function holistically, and we take into consideration the overall health of the patient and how that affects the foot function and your lower limb function. So if you like to train as a podiatrist here in the UK, all applicants must have a minimum of 5 GCSEs, and that include maths, English, and your sciences. And in addition to that, you have to have 3 A levels or equivalent, including a biological science. If you don't have A levels, there are other routes to it. So you can either, if you're an HND holder, you can use that to apply. Or if you have a previous degree in health-related subjects, you can use that to apply to the university as well, or a science-based access course. So you can use, in addition to the 5 GCSEs, all applicants must have the 5 GCSEs. So the training is delivered in the university, so it's a degree course. And there are, I think, 13 universities at the moment in the UK that offers the training. In England, Ireland, and Wales, the BSc course lasts for 3 years. And if you're over in Scotland, it takes 4 years to train to become a podiatrist. And there are 3 ways you can train here in the UK to become a podiatrist. The apprenticeship is the first one, and I think it's a new scheme introduced by the UK government to get more people to train and to make it easier for people to, train as a podiatrist. So the apprenticeship course gives you the chance to earn a living whilst you're training in the university to become a podiatrist. So you secure an employment with a healthcare provider, which is the National Health Service here. And whilst you're in the clinic, under your clinical mentor, you're also, in the university as well, learning the theoretical parts of how to become a podiatrist, which I think is fantastic because it gives you the opportunity to choose these 3 ways. It gives you the opportunity to choose the best, way around your maybe family life or commitment or your employment or your previous degree. It just gives you the chance, to choose the best way that works for you. And the common one here is the BSc degree course, which I stated earlier. So if you're here in England, it takes three years to train, or Scotland 4 years to train. And it's one of the common ways we train when you've just left college or school. And another good way you can train is the pre-registration master program. So this is suited for people or applicants who already have a degree certification in either healthcare course or in other subjects as well. So it's a fast track because you already have a degree. So the program lasts for 2 years and is done in the university as well. So once you qualify, it gives you the chance. You also attend a master certification as well, which I think is fantastic. So those are the 3 ways you can train at the moment here in the UK. So during your course as a podiatry student, you will learn about anatomy, physiology, the theories behind what we do, management plan, and other people that you have to involve in your patient's care. And as you proceed through the year, you're sent out to clinical placement where you learn the practical side of things, and you can work alongside other qualified and experienced podiatrists. So with that, you can improve your skill set. You'll be able to do nail surgery where you can give local anesthetics to do minor surgeries on foot. For example, taking off ingrowing toenail or debriding painful corns. So it gives you the chance to do that. And at the end of your program, as a podiatry student, you have to have a minimum of 1,000 of clinical hours, either in NHS or private practice, but they'd like for you to have, go into both areas, NHS and private, to give you a mixture of experience. And this is a requirement for you to have this 1,000 hours of clinical practice before you can register with a professional body, which is the Health and Care Profession Council, HCPC. So once you've passed your course and you graduated, you'll be encouraged to join the Royal College of Podiatry, where you have a vast number of support available, for podiatrists there, where you can do courses, you can go on conferences and seminars, and you have to register with the Health and Care Professional Council before you can start working as a podiatrist. So as a podiatrist, you can either work in the National Health Service or you can go into private practice where you set up your own business, which I think is fantastic, depending on your family structure or you have other commitment. You're able to, choose whatever works for you. You can do a 9 to 5, in the NHS, or you can even do both. You can work 4 days in NHS or 1 day in your private practice. So I think not all healthcare professionals are able to do that, but we podiatrists, we're so fortunate that we can, we have that opportunity. And let's not forget, academic qualification is not everything. So as a podiatrist, you must have a great communication skills. You must know how you communicate with your patients in the way that they understand, what you're diagnosing them with, your treatment plan, who you're going to be getting involved, and even the advice you give to them. And you must be able to work independently. So in a typical podiatry practice, you might just have a clinic where you're the only one working there. So you plan your day, you plan the patient coming in, you treat them by yourself. And if you need to get other healthcare professionals involved in their care, so you have to work with other multidisciplinary team. So you have to know how to communicate with your other team as well. So you not work independently, and you have to know how to be a team player as well. And like every other healthcare professional, you have to be caring, you have to show empathy, your reasoning and problem solving skills must be really good. And you have to be flexible as well. And with the way the world is going, technology, we use technology here as well. So you must have good IT skills. For example, you want to write a letter to, let's say, the diabetes consultant, because your patient's diabetes glucose level is, is not well controlled. So you must be able to use just simple, IT skills for that. So there are different arms to podiatry. So you can either work in a general practice where you manage your patient's toenail, callus, corns, or you do like a chairside insoles that you put into patients' shoes just to, offload pressure from their feet. Or you can specialize in diabetes and vascular side of things, which I'm a specialist in. So with that, you manage your patients, you manage them by either giving them advice and treatment before they get problem, or you manage them when they develop a problem, for example, ulcers and ulcerations and, infection. So you work with them to prevent a limb loss or even death. If you don't want to do that, there's also a chance of specializing in biomechanics. So you look at the way you walk and deformities more closely, and they can prescribe like exercises to do and orthotics therapy, or they can even cast your foot as well to give you insoles to correct deformities or offload pressure. If you're into sport, there is also a chance for you in the sport world. You manage people, the athletes or other sport professions. So you look at the mechanic of how their sport plays and how that interferes with the foot function. You can also do nail surgery, where you get your patients and you just inject local anesthetics into their toe, and you can easily just take the toenails off, just so it can prevent future complications such as infection, especially in people with diabetes or high-risk foot, we say. If you like working with children, there's also an opportunity there for you. They refer to us as podiatrics. So you work with children, you keep them mobile, and if they have any congenital problems, you help, like, for example, if they are born with overlapping toes, you can help them by making just simple, gadgets just to sit in between the toes, just to prevent them rubbing and causing pain for the child. So you keep the child walking and they can go play and just be a child, and you can progress your career and do more courses to become a podiatric surgeon. And not all podiatrists work in the clinical practice. You can also go into teaching. So in education, you're in the university giving, lectures and teaching other upcoming podiatrists and giving, and in conferences as well. Or you can specialize in research. So those are different areas that different areas of podiatry. So like I said earlier, we work with other healthcare professionals as well. So doctors, nurses, endocrinologists, physios, diabetes consultants, and we work in the community and in the hospital setting as well. We also go to the patient's home to see them if they're unable due to their health reason to come to the clinic. We go into their homes and offer treatments to them there. So the career prospect for podiatrists is really good. Like I said earlier on, you can either go into NHS or set up your own business where you book in your patients come and see you. So within the NHS, there is a structured care pathway, the career pathway. So once you finish as a podiatrist, as a podiatry student in the NHS, your first level is a band 5. So that's the entry level. And as you gain more experience, you do more courses, you do more shadowing with the more experienced podiatrists, depending on the areas that interest you, then you can proceed to the next level and become a band 6 podiatry, which what I am. And also you can become a team leader. So you lead a set of podiatry team, or you can become a band 7 in the clinical practice as well, where you're able to prescribe more antibiotics, more tablets for the patient. And like I mentioned earlier as well, you can become a podiatric surgeon where you do surgeries on the foot and ankle. And the career in podiatry is rewarding and challenging at the same time. And I think it provides a good work balance for whoever is interested. I mean, for me, I'm a mother of just a boy at the moment, and I just do 4 days in the NHS and I do 1 day in the clinic, in a private practice. So I'm able to, juggle being a mom and working in the NHS stress-free. So if you're considering podiatry, I would say go for it. And I hope in the nearest future, Nigerian University will hopefully be able to, provide this course so that there will be more podiatrists in Nigeria to help our community and just to keep Nigerians mobile. Thank you. So I'll take any question you have.
Thanks, Kemi. I was getting interested until you talked about pulling nails. Anyway.
No, that's scary.
And then you started mentioning surgery, and I was like, nah, I'll stick to what I'm doing. Okay, Angela has a hand up. She has a question for you. Do you want to stop sharing the screen so that we can get...
Hi, that was wonderful, Kemi. I'm a podiatrist in Jamaica, having trained in London as well. A lot older than you, so I've been at this game for about 30 years, and a vast experience also, obviously within all the fields. What I think it's really interesting to hear how podiatry has progressed from when I was a student. But I imagine that when in Nigeria, which is where most of people are watching, it's going to be very similar to Jamaica. I moved from London after 25 years practicing there, with all the facilities and everything fantastic, and moved to a developing country. And it's very, very different. So you find your scope of treatment will be really, really wide, hugely different from what you're used to in the UK. And it would be wonderful, Kemi, I would like to think if at some point you feel to go back to Nigeria to give your services to your people, which is what I did for Jamaica, because there are only 3 podiatrists in Jamaica. So I'm all over, it's a small island, but I'm all over the place. So they need us. Foot care is really lacking and people, there's a very poor understanding of foot care. So the more I can encourage you to find yourself in Nigeria in the future, that's what I would do. And I really do hope they get to sort out a school there, because the podiatrists in Jamaica, the 3 of us, 2 are from the UK and 1 is from the US, because there is no podiatry course done at our university. So excellent presentation, and I'm glad you're encouraging podiatry around the world. So wonderful. Thank you.
Thank you.
Thanks, Angela. I mean, you have more than we have in Nigeria at present. And one of the things Gintavenes is aiming to do is to improve that situation, looking at courses. We did have a program before coronavirus hit. And one of our other podiatrists, which she'll be speaking later, Fumi, she was on ground. She was on ground and she did some training, but of course it has to be ongoing. And it'd be nice to have a course where people can actually pass through and then have their clinicals and so on and so forth. Thanks, Angela.
Thank you.
Anyone else? Any questions for Kemi? Anybody? Okay. Linda?
Thank you very, very much for this awareness. In fact, it sounds so interesting, really, really interesting. But now, if I am going to go study this course, I am the only science subject I actually know and have is biology. I know nothing about chemistry, physics, and all that. So would you still advise I go for, yes, I have a first degree in education accounting.
Okay.
Now, would you advise I still go for another first degree, or I just go straight to master's? Thank you.
Thank you, Linda. Yeah, so I'll still advise you to go for podiatry. However, that's dependent on the university you apply to. So it's better when you apply to the university. In fact, you can just send them an email, or what you've just said now, put it in an email, and they're always very, helpful. They will tell you what other courses you need to do, or if what you have already will be sufficient enough, or if you just need to do maybe like a top-up course or like an access course here, or something online, which you can do. And I think, yeah, you'll be able to get into podiatry.
Okay. Hope that's helpful, Linda. Anyone else? Any questions for Kemi? All right. Okay. So let's move on. So we talked about podiatry, and as I mentioned earlier, Fumi is another one of the podiatrists on the team, and she's going to talk about how to check your feet, which is what Prof mentioned earlier. And so just have a look. And this is, yes, even if you're diabetic or not, but it's more important as if you're living with diabetes. This is very important. So let's do this.
Good afternoon, everyone. We are going to be doing a basic diabetic foot examination here. And whilst we're doing this, I will be examining these pair of feet here and letting you know what we do when we do a typical foot examination and what you should be looking for yourselves. So my name is Fumi Ogunyoye. I'm a community podiatrist, and I do quite a lot of work with the diabetic foot. So here we go. When we start with the foot examination, we're looking to see what we have before us in the clinic, and we want to see what this foot is telling us. We want to understand where the patient is. We want to understand the foot health, and really and truly, we want to help this patient understand what they need to do to keep their feet healthy. So we're going to start by looking at a few things. The first thing I'm going to do is we're going to talk about the appearance of the foot. When we look at the appearance of the foot, we look at the dorsum, and also we look at the plantar. We look at the heel. We check the heels to make sure that the texture of the skin and the type of skin is intact. So what we mean by that is that there are no breaks in the skin, especially around the heels. This is a very common place to have breaks in the skin. So we're going to look in between the toes as well. Look in between each and every toe. This is something we do on every single examination. And I have to say, I actually do this even with non-diabetics. The basic thing I will do with any patient I have is I feel their heels, look on the top, look at the bottom, and look in between each and every toe. Now, when we talk about the diabetic foot, the importance of ensuring that we do a proper examination is to make sure we're actually stating what is going on and matching that with whatever it is we are reporting on the paper. Now, if, for example, there was maybe a break in the skin in between, because sometimes we have feet that are pretty sweaty, or feet that for whatever reason, sometimes maybe people may not be changing their socks adequately, or whatever it is, they get a bit of maceration, dampness trapped in between the toes. So we always have to be careful to look properly. When we do look, what we need to do is give advice to the patient. If the feet are a bit damp, or they're a bit of, athlete's foot in between the toes, we advise them that they should just carefully dry in between their toes. So especially after having a bath, carefully dry in between the toes to make sure that the toes are nice and dry in between. Another thing that we can suggest is to use surgical spirit on a bit of cotton wool or on a wipe, and just wipe in between the toes after having a bath. That can help encourage a healthy skin environment in between the toes. Now, the next thing I will want to do is, after having a look at the feet, the skin, is everything intact? Is it not intact? Especially with the heels. Heels are a very, very common place to get fissuring. Also because, obviously, depending on the environment, there are some environments that can be very drying. So what you find is that some people are prone to getting splits in their heels. What we always suggest is generally for people to moisturize the feet daily. Now that is so important, because when you have dryness in the skin, that can also encourage the splitting around the heels. What we want to avoid with the diabetic foot is having splits around the heels. Splitting around the heels can cause worry, because it can be a point of entry for infection, and that is one thing we want to avoid. So check the heels carefully, ensure that there is no splitting. If there is splitting, examine it, ask the patient how long have they noticed this, if they have, and what are they doing about it. So if the splitting has hard skin around the edge, what we sometimes will do is we'll gently debride the hard skin. If it's bleeding, if it's pretty open and needs a dressing on, we will put a dressing on. Obviously, covering the heel is quite a tricky place to cover, but that's something that will be done, because you want to ensure that there is no break in the skin that is not dressed. So a simple dressing to just keep the area clean will be good. So this is just where we are doing the foot examination. Now the next thing we want to do is we check for temperature. And this is something that I do just by gently using my hand in just checking the temperature. In some cases, when we deal with diabetic foot, we may have the odd occasion where you may have somebody that may have, a bit of temperature difference in the feet, or a bit of a gradient. Maybe one part of the foot is cold, one part of the foot is warm, or anything that sort of, sticks out to a practitioner, that is there a sign of possibly something going on. When we talk about the diabetic foot, you sometimes have people that may have Charcot joint, and that's where you can get this inkling that there's something going on by looking at the joint and looking at the texture, and also when we feel, usually you find there might be a bit of a temperature change. So just to bear that in mind. Another thing I would like us to note when we do foot examinations is we look to see if there's swelling or edema. Now that is very important, because although we're doing a diabetic foot assessment, obviously we're looking at the whole patient. If I do get occasions where you have swelling, whether it's pitting, which is when we put our thumb and if it leaves an imprint after a few seconds, or non-pitting, where you put your thumb in and the skin just plumps out again without any imprint of your thumb, is to ask the patient. We ask them, when we do these examinations, we generally ask about their medication, what they are on, because sometimes, people may have other matters going on, for example, high blood pressure, kidney issues. So it's always good to ask them, is your GP aware of this? Is your doctor aware of this swelling? If they say no, or if it's not been managed, then we will signpost, go and see your doctor, go and speak to your doctor, let your doctor know about what's going on with this swelling. Next point I would like to raise about foot examination is also just looking around to see if there are any discolorations. Sometimes, we may see discolorations. Sometimes you have people that have like a mole, or they might have a skin tag, or just this, it's something they were born with, like a birthmark. It's good to note that. And especially if it's maybe something you're doing on an annual basis, because with the foot examinations for diabetic, we usually recommend them at least once a year. Sometimes you can compare your notes. If you notice maybe last year this was about, they had a mole and it was about 2 centimeters in diameter and it's gone to 4 centimeters. Obviously that's the point to note and then to take further action by maybe referring them on to the GP to have a look. Other issue with doing diabetic foot assessments is we check for pulses. So I'm actually using my fingers here. We check for the dorsalis pedis pulse, and that is usually something that you can find just along here at this very point where the first and second metatarsals gap in between, just around there at the top, and that I can feel. And also you look for the posterior tibialis pulse, which is usually found around this area, just underneath the ankle, just there, and that we will just have a feel. Yep, and I can feel that again. I'm going to try and use the Doppler once I get a moment after I finish this basic examination, but I just want to get through a couple of other points. Next thing is we are going to do the testing with the 10 milligram monofilament. So what we do is we're going to ask the patient if they feel touch. And we do that by just gently prodding this without this bending like that. So we want to just gently touch and ask them, do you feel that? Do you feel that? Do you feel that? And if, of course, they feel it, they will let us know, because what we want to do here is to establish whether or not they have any sort of sensory impairment. Some people have neuropathy, and this is where the feeling in the feet can be affected. The nerve supply to the toes can be affected. So that's just something to bear in mind. When we do this with the monofilament, we use certain spots. I'm going to use the bottom of the big toe, the third, the fifth, the PMP1, plantar metatarsal 1, plantar metatarsal 5, plantar metatarsal 3, and the heel. And also I like to check the arch, and I also like to check the lateral aspect as well, and check the heels. So obviously it is entirely up to you how you want to carry out the monofilament testing, but you want to get a good idea as to whether or not this person has neuropathy or not. And then finally, what I would also like to suggest that you do when you do a foot check is to check for deformities. Some people may have a bunion, some people may have, a hammer toe, some people may have a rigid toe, some people may have nothing, as you can see with this person here. But the key thing is to check for deformities and check for lesions. So you might find a bit of calluses. Some people may have callus on high pressure points. Some people may have corns. So we check, we find out where these lesions are, see what they're like, and we obviously give advice and we give treatment. If we have a corn, if we have, calluses, we take them off, we debride them. We check the nails as well. We see what the quality of the nails are like. Are they nails that are thick? Are they nails that are ingrowing? Are they nails that are fungal? We check the quality of the nail and we see what that is like, and also we give advice on that. So the most important thing I would like to round up on is when doing a basic diabetic foot check, we want to make sure that we're checking to see if the foot is intact, if the pulses are there, if there are any lesions, if the patient has any concerns. We also give them advice on how to take care of their feet, how to gently cut the toenails, how to keep their feet clean, and how to cream their feet. We give them advice also about not doing anything risky, using blades, using chemicals to burn out corns and that sort of thing. We don't advise that. So unless if I can help you any further, that is the basic diabetic foot examination completed. Thank you.
Thank you so much, Fumi.
Good.
Do we have any questions? Any questions for our podiatrist? Any questions for Fumi? Okay, we have a question from. Okay. Go on, Fumi. You wanted to say something?
No, go ahead with the question first.
All right. Okay. Tola, please unmute yourself.
Yes. Hi. Thank you, Fumi, for that presentation. I mean, I just wanted to ask. My son has his first toe on the left foot. It's always going black, right? Even when it grows and we trim the nails, every time new nail comes out, it's always black. It doesn't hurt. It doesn't complain of any pain, but it's just always that color. Do we know why that is?
Did you say the toenail or the toe?
The toenail.
Toenail, sorry about that. That, you see, is not something I can give any advice on, because, you know, we to give a proper advice, we have to see the person, we have to do a proper clinical examination. And I wouldn't want to give incomplete advice. I think the best thing to do is, is to take him to a doctor, because doctor will know what is going on. It's not right clinically for me to give advice on what you've just said there, because I don't know. We have to take a full examination from a person, especially when it's a child. We have to be extra careful. I'm so sorry that I cannot help you any further. I think it's best to just take the child to a doctor, so the doctor can at least have a look and give you proper advice. Hello? Okay. I'm sorry, I know it sounds like I'm not being helpful, but I think
that makes sense.
Extremely careful, especially when it comes to child. So I can speak to you generally though. Is that okay?
Tola, is that okay? Yeah, go ahead.
Okay, so generally speaking,
sorry.
I will speak.
Sorry, I was muted. That's why I couldn't answer. Sorry.
Okay, sorry. So what I will do is I will say, generally speaking, we see a lot of presentations of black toenails. Now it depends. Some people, their nails, the nail is firmly attached to the nail bed. Some people, the nail is not. Sometimes there's a history towards when it started. With some people, it could be a matter of there's been damage to the nail bed that renders the fact that nail will not be attached to the skin. Now, if you say the nail itself is black, not the nail bed, because sometimes, sometimes it might appear that a nail is black, because it may be something else going on underneath the skin. You understand me? So I think just to be on the safe side, it is better to see the GP, just so that the doctor can just have a proper look. And even sometimes the dermatologist might also even be good, because I know we don't have too many podiatrists. Can I ask which country are you calling from, please?
She's in the UK.
Okay, in the UK. Oh, well, you know what? Take the child to the GP. That's the best thing to do. Honestly, that's really the best thing to do, to be on the safe side. And the GP might want to refer the child to a dermatologist just to be on the safe side as well.
All right. Thank you so much. We'll do that. Thank you.
No worries. No worries. I just wanted to clarify a point on the presentation, because I don't think I was very clear on it. When we use the monofilament, this is probably more like for clinical purposes. We have to apply sufficient force on the monofilament for it to bend or buckle. So that's just a clarification point I wanted to make on there. Is there any other questions at all?
Yes. Can a person living with diabetes have pedicures? And if yes, how often?
Now, you see, that again is something that, I don't like to sound like I'm not being very helpful here. When people have diabetes and they want to go for pedicures, I have some patients I see, I usually discourage them from having pedicures, because some of the people I see are clinically vulnerable people. And generally speaking, when you say pedicure, I don't know what the pedicurist is going to do. We don't know if they're going to think, oh, there's some cuticle nail here, I'm going to do this. Oh, there's some hard skin there. We just don't know. And I just generally say to people, have your diabetic foot assessment and care anyway. After you do that, if the person that sees you, your podiatrist, says, you know what, actually you're very low risk, you've got excellent feeling in your feet, you've got no break in your skin, you're quite healthy, you can see, you've got good feeling. So basically, if, God forbid, if something happens and there's been no change in their condition, then they'll be fine, even if they went to a pedicurist, maybe they did something and it's a chance they want to take. But generally speaking, I wouldn't advise a diabetic person to go, because I don't know what they want to do. Some people have cons, and some people think, they'd rather go to the pedicurist person because maybe it's cheaper for them, but it's not safe for someone that's doing just pedicures to debride your corn, to do certain things, because we use sterile equipment. We are a regulated profession. And I just think to be on the safe side, you just have to be serious with your diabetes and just treat it as, you know what, I want to avoid any risk. So my solution to that person is, if you just want to go and have your nails painted and make them look pretty, there's nothing wrong with that. Because I have patients that are diabetic that come for their clinical need. You know, they might do their corns, their hard skin, if they have fissures, we'll do all of that. And then they might say to me, you know what, let me just go and have my nails painted nicely. Don't cut them too short. So they then go and have their pedicure, and the pedicure will make the nails look pretty. And there's absolutely nothing wrong with that. So the question here is, I don't know what the pedicurist will do. So that is a chance a person is taking of their own volition if they want to do that.
Okay, thanks, Fumi. Chiji? You can ask, yeah.
Hi, good afternoon, everybody. And
good afternoon.
This has been most enlightening, and thank you for the very clear presentation of that. So it's clear. But however, I'd want you to reemphasize there's something in your presentation you're talking about when examining the feet. You talked about two types of edema, one that can depress and the other. It didn't come out quite clear. So I'd be quite happy if you can roll around that one more time, please. Thank you.
Unmute.
Okay, thank you. Thank you. So the reason why I mentioned that is this. Now, some patients come and see us and they have other treatments that is being undertaken by their GP or the diabetic specialist, or they have someone else managing other issues concerning their health. Now, when we have patients that come and see us, this is just generally what we do when we do a lot of assessments. So when it comes to the pitting and non-pitting edema, you know, what we usually do is explain to them, because pitting edema usually refers to when you have accumulation of fluid in the soft tissues. And there is a difference as to what is actually happening in the body. You know, non-pitting edema is usually localized in certain parts of the body and lower limbs, and there are different causes for them. And I don't like creating this environment of worry for my patients. And I don't want to say to them, oh, pitting edema, you could have this, you could have that, you could have that. And I don't want to say that to any of them. So what I prefer them to do is go and see their GP. If there is something there, for example, there might be other medical conditions that are causing this pitting, which the GP maybe is not aware of, then it is entirely up to the GP, because you see, that's not my own level of competence to tell them, oh, you may have this because you have pitting edema, or you may not have that if you don't have it. So what I always do in all situations is I always remember, I am a podiatrist, this is my own specialism, but I'm not going to tell you, you may have this, or this is a sign of this. So, you know, I don't want to put that sort of worry in them. What I say to them is go and see your GP. If they go and see their GP knows them and knows their health and general condition, and then can decide on that. So basically, the difference between pitting edema and pitting edema can sometimes be an indication, in some cases, of certain conditions that may affect the thyroid, for example, you know, lymphatic system, for example, you know, those sort of things. Yeah. So it's just a matter of letting the patient know that there is a reason for them to go and seek consultation with their GP. And I think that is my personal way of handling things. I don't take ownership of whatever is causing that or what could be causing it. So I sort of prefer you to see your GP.
Great, yes. Very important point. Any more questions for Fumi, please? Okay, anyone? Okay, if you think of any questions, we can take them later after our next speaker.
Please, can I just add one final thing?
Yes, please.
I know we were talking about foot examination, basic foot care, but I didn't talk about footwear, and I didn't know if anyone else was going to talk about it. But just the basic general advice we always give is, please always check inside your shoe run your hands through inside your shoe, just on a daily basis. I know it sounds like a basic thing to do, but before you put your shoe on, maybe before you put your socks on, just run your hand inside your shoe and look underneath your shoe, because sometimes we might have things that are going through the shoe. And when a person is diabetic, it's just best to ensure that, it's such a very simple thing to just check underneath your shoe each day, check underneath and then check inside the shoe. There's nothing there. So that's all I'd like to add. Thank you.
Somebody just said, is it okay to wear high heels? Any disadvantages to that?
You see, when you talk about high heels, again, that's another issue. How high are they is the question. How long are you wearing them for is another thing. What is the shape? What's the depth of the shoe? Do you need to wear it? Obviously, wearing high heels destabilizes the body. It's not recommended. So if you're going to wear high heels and you're going to a party, you're going to sit down and you're going to take your heels there, maybe just wear them for 10 minutes or something. There's nothing wrong with that. But to wear high heels as a standard for your day is definitely not a good idea. If a person is diabetic, usually most high heel shoes I know of, they usually force the foot into a narrow shoe at the very front. And that's where a lot of people get problems with corns. People can develop ulcers and all sorts of things that are not very nice. So if you can, please avoid high heel shoes. They look pretty, they look nice, but I can tell you that when you're looking at your foot and your health, high heel shoes can affect your back, your hips, your knees, lots of other parts of your body. So it's best to avoid them generally and wear them only, if and when you need to wear them, and have proper pair of shoes in your bag for wherever you're going to for a function.
And I just have to, what Fumi just saying in regards to the high heels as well. So like Fumi said, we don't really recommend, especially if you're diabetic, high heel shoes. Yeah, I know go area. I mean, for diabetic patients, they might have neuropathy, so they don't have good sensation. So you might feel you're wearing high heel, oh, they feel comfortable. I don't feel any pain, or I don't feel any pinching. It's probably because you don't have any sensation in your feet. And before you know it, when you take your feet out, you've probably got blisters, corns, and that's just the beginning of, some of the diabetic foot problem that we do see in the clinic. So I would just say, like Fumi said, if you're just gonna take picture with it, just sit down and look pretty with it, that's fine. But walking around with it, I would say it's a no-go area.
All right, thanks, Kemi. Another question is, people using things like rub on their feet and things like that. What do you say about that?
Well, to use things like that, you see, the key thing is, provided you don't have a break in your skin, that's the number one thing. No break in it, as in no entry point for whatever we want to get in. Using things like rub, again, I have patients that have used balms. Maybe they have arthritic feet sometimes, and they say, when they use that, it helps them, they feel better. I personally don't see anything wrong with that, but I just think the key thing is, if you have any break in your skin, don't use any of those things. That's the first thing. Secondly, provided they don't have any additional chemicals like salicylic acid or anything like that, I think really and truly they should be fine, provided those two conditions are met. But please let Kemi also add to this.
Yeah. So in regards to vapor rub or what you've just mentioned, I think as podiatrists, we know licensed to give people advice to use that, because vapor rub, they're no license for feet or as a moisturizer. It's a decongestant, so we don't really advise people to use that. It might work great for you, fine, but in terms of our profession, we don't. It's out of our remit.
Okay, so for people living with diabetes, what kind of things do they use on their feet to prevent them from drying out, which can lead to the cracks and so on?
So Vaseline is good. I suppose you can all get Vaseline wherever you are in the world or in Nigeria. So I would say Vaseline is really good. Or just even like shea butter. You can use shea butter, just gently rub it in. But just make sure whatever moisturizer you use, don't put it in between your toes. Because as you can see in between the toes, hair doesn't get into it. So it's always warm and damp. And you put in moisturizer, you'll be adding more moisture in between, and that can increase your risk of getting athlete's foot, and you can start having breaking, like splits in between, that can lead to infection and ulceration as well. So Vaseline and shea butter.
I'll also add to that. That's excellent. Obviously, it depends on where you are. But if you're, say, for example, maybe over like in the UK, creams like CCS are very good, especially for people that have a lot of dryness around their heels and cracking. Urea creams with urea in them can be very good as well if people have excessively dry skin. But what I'll suggest is if you have excessively dry skin where something like Vaseline or shea butter doesn't work, speak to your doctor again, because there's so many things doctor can advise and so many specialist creams that they can offer.
What about powder?
I wouldn't suggest powder because it can harden.
Plug up
exactly in the interdigital areas and can even cause more problems. So it's better to dry it. Maybe, for example, with a wipe, a bit of surgical spirit is not a bad idea, but I wouldn't suggest powder either.
Okay. So last question. When you detect blisters or small, also ulcerated wounds, what can you use to dress the wound? Do podiatrists dress wounds? That's from Elizabeth in Nigeria.
Do you want to go for me, or should I?
Well, I will go from the perspective of a community podiatrist, because you work in the NHS, Kemi, don't you? Mm-hmm. Now, I did work in the NHS. I did my rounds for many years, but as a community podiatrist in the private sector, mm-hmm. the way we work and the way we've been instructed to work is we don't do dressings, right? When I do work and I come across things, we do come across ulcerations. I come across them almost every week. My standard go-to is I will dress it. I have a standard email. We have a clinical standard email we send to the whoever it is. It might be a nursing home, an individual. We say, look, we don't dress these wounds. We don't do wound dressing in private care. We are not licensed to do that. So we'll dress it. We'll send them a standard letter to their GP. Some of them can do it themselves. The district nurses will take over. That's basically what happens. If I come across a diabetic with a wound, which I have done even in the nursing home recently, they wanted me to see, I took him off my list after I saw him. I said, look, this person needs NHS multidisciplinary care because it was a diabetic that had an active ulcer, very high risk feed. And he needed that care. That was the level of care he needed. So I would let Kemi carry on. But when it comes to private treatment, if you go to a private clinic in the UK, for example, that is not the sort of thing we take on. We sort of always refer on. We have a duty to do so. I believe under the NICE guidelines, that is what we have to do.
Yeah, so as a podiatrist here, we do dressings for our diabetic foot wounds. But
this is in the hospital.
In the community clinics as well as an NHS podiatry. For me, it's right. If you work in a private practice, the way you work might be different, because with diabetic patients, you really have to be careful because they have more comorbidities, and you just have to, liaise with other healthcare professionals. So in NHS, we manage the diabetic, diabetes patient there. So when you come across a diabetic foot wound in the NHS, we do dress it, but dressing is just one factor in what is causing the diabetic wound. So we do assessment, check your circulation. Do you have good circulation to heal the wound? Or neuropathy as well. We do the sensation. Do you have good sensation? How did it come about? So we can either just put like a hydrating gel just to keep the wound healthy, moist, or if your circulation is really bad, then we might just want to keep, just a dry dressing because you don't want to be hydrating it if you have poor circulation. So we might need to liaise with the vascular team and just, get them to do more further assessments on you. And yeah, so the simple answer to the question is, yeah, we podiatrists, we do wound dressings.
Great, thank you both for that. All right, we're going to move on to the next speaker. Her name is Lion. She's a voice for diabetes in Nigeria, West Africa. She has been living with diabetes for 20 years, type 2 diabetes. Initially, it started as gestational diabetes. She's a founding member of the Diabetes Limb Salvage Foundation of Nigeria, which is a sister NGO to the International Limb Salvage Foundation. So I'll let her talk more about living with diabetes. Lion, over to you.
Hello.
Hello.
Good afternoon. Hello. Good evening, everyone. And good afternoon over there. My name is Lion Osai Hoi Ethel Chima Wongugu. I'm a person living with diabetes and living with 2 other complications, obesity and neuropathy. And I'm a mother of 5 beautiful daughters. And I'm married to a wonderful man, Chima Wongugu. And he has been my pillar throughout this journey. And I'm born to a family of 12, 4 men and 5 ladies, where I'm the last child. And my both parents lived with diabetes and also passed on with the complication. At the right age though, and unfortunately I've lost 3 of my other brothers to NCDs too, diabetes and hypertension, complication, and prostate cancer. So far, myself and my 2 elder sisters are living with diabetes. And we are doing very well. I have lived with it for 22 years. Point of correction, she said 20 years, it's 22 years. My first experience with diabetes was when I was diagnosed, when I was told I wasn't diagnosed. I was told in the second trimester of my second daughter's pregnancy that I was having a gestational diabetes. I was educated and I was managed well and I gave birth. She was 4.9 kg and it was normal birth and it was fine. 6 weeks after, I was checked, I was fine. And the 3rd child's pregnancy too, it was also gestational, same method, I was fine, though that came with a CS because I was spotting during labor. So it was fine, but 6 months down the line postnatal, I was having issue with the vaginal infection. And then I had to go back to the hospital. I told them I was not comfortable with my body. And they did a blood work because of my history of being a gestational mother. And they checked and they found out that my sugar was over 400. And I was referred to an endocrinologist who now did more work and more investigation and then diagnosed me with type 2 diabetes. It came as a shock because I have never had it. I never expected that. I was just young. I was 35 years old. And my mother just died some few years ago. And now I'm 35 and I'm being told that I'm living with type 2. Well, one interesting thing that I met at that clinic was I met a woman who just lost 2 pregnancies. In fact, she had a stillbirth and she was counting herself lucky that she now told the reason why she lost the two pregnancies because her sugar, she never knew she was having gestational. But now she was told that I'm lucky. So I felt good. But the good thing the endocrinologist also did was he educated me, he told me about his mother's history, that his mother lived with diabetes and she's even old and that she's doing well. So that encouraged me and gave me a very good encouragement. So after that pregnancy, I now started living with diabetes. I had 2 other pregnancies and that's where I had my 4th and my 5th, and I had CS for the 3 births. So I lived my life, I became a voice, I became an advocate, I started reading more. So I lived my life. Through the pregnancy, I had the community support, my family, my friends. Through the pregnancy, you need that, you can't do away with that. So I had my friends, I talked about it. I inject myself publicly. I tell everyone I'm living with diabetes. And then I give birth to my children, I breastfed. The 5 daughters I had, I breastfed them. And breastfeeding, I found that helps to put at bay complications of any NCD or any condition at all, and they can inherit from their parents. So meaning exclusive breastfeeding is very important. So thank God I did that for my 5 girls. So diabetes is not about ups and it's not about down. There are good side of living with diabetes. I became an advocate. I became a hope to the hopeless. I became a support system. I became a face of diabetes. And now I do my business. I'm an entrepreneur. I'm also a humanitarian. I speak in events, I speak on TV to encourage people. People call me from all parts of the world and they need support because they say I'm strong. Yes, I eat almost everything. But one thing I must tell everyone is my endocrinologist is compulsory. My nurse is compulsory. My dietitian is compulsory. And you are your first daughter. I am my first daughter. Meaning, whatever they told me to do, I make sure I do it and understand it. So I have lived with diabetes all these years, not thinking that all is perfect. It's not true. It's difficult. You need your family support. My husband, my children were there. I have had hypo where my daughter saved me. I have had Ingro. I had the podiatrist talking about Ingro, where my podiatrist is from America. They are not, we don't have them in Nigeria. I live in Nigeria. I don't live in UK like most of you. We live here in Nigeria. So we have volunteers who come in from the US to support us here. So if not for my being a voice, I wouldn't have met this great, wonderful people. So when you are living with diabetes like I am, don't be afraid, be bold, accept your condition, don't live in denial, don't be confused. Eat everything in moderation. If I want to fast forward my experience, just last year, I found a secret that the doctors have been talking about, but we didn't understand until a wonderful endocrinologist just looked at my history for 21 years and said, look, ma'am, you're doing very well. You're eating right. You've been trying to lose weight. You're not getting it right. Let's look at what is happening. You're not exercising enough. She told me to exercise every day. I had some people asking questions and I started exercising every day. And guess what? My glucose is, my A1C, my HbA1c was 9.1, but now it's between 5.0 to 6 in 6 months because I exercise every day. I eat the same thing, but that exercise is key. So you must exercise. I heard what Dr. Fasamadi said. Everything he said is fantastic. It's true. You eat everything by moderation. No mineral, no salt drink. All what the doctors have been saying, please take it serious. That is how I have lived my life. And I'm living out. I just marked my 53rd birthday 3 days ago. And it's awesome. It's awesome. My 5 beautiful daughters, I don't want them to live with diabetes. So I educate them. I tell them about diabetes and they are eating healthy. And one good thing diabetes did for me and my community is that we now eat healthy. We live healthy life. You must be deliberate about your lifestyle changes, deliberate, and be very, very committed to it. So that's what I did. And that's my children are educated about it. My husband is. When I'm having a party, I don't serve no mineral, fruits. Zobo made by me with sweetener of dates or pineapple. So, and you also serve healthy food. So you have to be an example of what you're preaching. And I've lived this, I've done this for 22 years now, because my daughter that I had, the first gestational was is 21, so I had pregnancy. So my all is win-win-win. I'm a voice and speak on WHO, I speak with IDF, I represent Africa because of diabetes. So what more? Will I say is a curse? No, it's a blessing. So we need to live above it. I'm not going to die. So my parents lived 93 years. My father was 92. Official age, though they say is 112. My mother was 83, though she died from complication of foot ulcer. But today, nobody on my watch, on my watch would die of diabetes because I wouldn't allow that. That's why I'm standing here to speak today. And I'm telling everyone here, I can see the questions coming in. Please don't be confused, don't be afraid. We got your back and you're not alone. WHO just launched Nobody will be left behind. We just launched Global Diabetes Compact. I'm a member of the Blue Circle. You can join also. We just launched that and nobody will be left behind. Please don't think you're alone. If you are a man, get help because diabetes will ruin your relationship with your spouse. If you're a woman, diabetes will make getting pregnant and living a normal life, enjoying your sex life difficult. It can cause blindness. It can cause all those complications. So please, take seriously your advice from your endocrinologist. Your here in Nigeria anyway, we already have endocrinologists. You are not blessed to have all what they are talking about in UK. We are hopeful that someday, according to WHO, we'll have others, and we pay from our pocket. So I want to thank everyone for giving me this opportunity. I can't say it all in just 15 minutes, but I think I have done very good job in telling you that it's going to be easy when we'll do it together. Thank you very much. God bless you.
Thank you so much, Lion. Do we have any questions for Lion? Any questions or comments? No? Okay. Oh, okay. Go ahead for me.
Thank you so much for for sharing this with us. I was going to ask concerning the exercise. Was this the first time you'd been told about exercising as in impacting your diabetes management in a positive way?
No, I have been. In fact, my middle name is Energy. I'm hyperactive. Where I work, where I volunteer, the hospital where I volunteer, they call me Energy because I'm up and down, moving around, working with the doctors. My life is hyperactivity. But the problem is my brain already knows that I'm hyperactive, so it wasn't using it all. So I needed to do brisk walk. So during the the Olympics, I noticed that when the doctor told me to do exercise every day, she wasn't specific like brisk walk or fast walk. So, but I observed that those doing brisk walk were very slim and they were burning so much energy. So that was how I now switched my walking, which I was doing every day, by just walking, but not doing brisk walk. So I now changed to brisk walk, fast walk. So I now discovered that my cardio activity of sweating was what was making my insulin sensitivity to go up. And now my insulin sensitivity is fantastic. Sometimes I have hypo and my doctor have reduced my drug. I was on 40 units. Now I am 26 insulin. And they reduced my glimepiride to 2 milligrams from 4 in the morning and 4 in the evening. That's remarkable, very remarkable. And I'm doing very well. I jog now and I have more stamina. So that's how I now say exercise, being deliberate about the exercise. So I've always been active. I'm not a very active person, but I wasn't doing it to burn. Like you said it, I think one of the doctors mentioned that you have to do a cardio, you have to make your heart pump that in any way, whether swimming or brisk walk. That's what I did that was different. So the sensitivity picked up. And my neuropathy is better too. And I also use the compression stockings thanks to my podiatrics from the US who have been managing me. They gave me compression stockings. So I have a very fantastic flow. I don't have aches in my feet anymore. I don't have that discomfort you have. So because I wear my compression stockings to exercise. And I'm always on sneakers. You mentioned shoes. I'm always on sneakers, even on native. So if I must wear shoes, I wear block heels. And I don't wear too high, 2 inches, but it must be block heel and the sole of the shoe must be lifted up. You must learn to know yourself and know what works for you. You don't wear tight fitting shoes. You must wear a size above your normal size. You will see that it works better. And one other thing I have a hard nail that grows into my skin. So my podiatrists call me 3 times in a year in this country, and they come and they use a special, you can't cut my nail with normal nail cutter. So they have, you guys, you know what you use in trimming the nail. So we are moving for that also in Nigeria, that they incorporate helping patients to trim their nail in the clinic. We are really doing something to make all the narrative change positively for us.
There's just a quick follow-up on that question as well. I mean, this is really, the reason why I'm asking this is I'm very interested to see, and I'm quite glad to hear what you're sending us. I'll be really quick because I know someone else has their hand up. In terms of this support you have, which is really great, are there local groups where look, people can go where they have this sort of thing, where maybe they have little ambassadors that maybe advise people, or just not even necessarily advice, but support, like the way you're supporting, even if it's in the most minimal way of doing the exercise, advising in a positive way. Are these things sort of generally and freely available?
Yes, we have a diabetic association. So we have that support group, which I belong. That was a support group the endocrinologist introduced me to 22 years ago.
Okay.
So, and I'm still there. And other support group have broken out of that place, still maybe private. So we have them in all the government hospitals across the 36 states, which people can belong. And then we're also encouraging private hospitals, like the Lions Club has also done something like that. We are trying to set up support group because they found that support group is the best way of managing it when people come together. So people can come to a support group, and we also encourage it in communities. Just have friends, let people hear your story, let people share. You see that the burden is amazing. So we have support group. I have like about 2 or 3 in my community here that people can come to. And every now and then I have outreaches where I meet people in different communities and assure them that you're not alone. So that also is helping us here a lot in Nigeria.
Fantastic. Thank you. Thank you, Lion. Kemi, unmute yourself and go for it.
Okay, thank you very much. Just to appreciate what you're doing, you're doing a very great thing, and well done for that. What you're doing is the equivalent, if I may say, of the NICE guidelines here that says that every new person diagnosed with diabetes must have, they must be signposted to self-management education. That is very, very important here.
Yeah.
I don't know how that works in Nigeria. I don't know if they do that in Nigeria, but at least, what you're doing is maybe it's just, if that's not part of what the Nigerian diabetic, whatever program does, but it's major here. And every part of the NHS, they do this. And there are other variations of the self-management education. There are major ones like experts, like Daphne for type 1 and so on. But, if you can find a way, if you can collaborate with people, work with people, and find a way that this self-management education can be, included in what newly diagnosed diabetic patients, in what they get, and then they're monitored, they're followed up. That's one thing I want to talk about. Then the second thing is that in UK here, there are loads of groups, exercise groups. People do groups and they just go out to exercise. What you've just done for yourself, if you can do it with a group of people in different sections, of the country, and people know, at a particular time like this, we all go for walk without, every little helps. And thank you so much, for what you've started.
Thank you. Ma'am, like what you said about Dr. Fatima, Professor Fatima is here, and he's the chairman of or president of EMSO. EMSO is supposed to be those insisting on what you just talked about now, making it compulsory that they give that health education. The nurses do that. But you see, they've been given Nigerian factor is affecting a lot of things. The nurses are supposed to do that. And not only that, we, Diabetic Association, is supposed to be present in all the hospitals, government and private. So, but like I said, this support group, people have seen the success of it. So when you are newly diagnosed, they refer you to the support group. But it's not everybody, they are not capturing it. So that's why we are now, because like somebody like me and some other few people will decide to put our face out there. If you have anybody, refer them to me. I give you a talk, and you see that living with diabetes is not a death sentence. It's not a death sentence. And then you also mentioned something like you said over there in UK, the second point you made. Can you just remind me again, please?
The exercise groups.
Yeah, the exercise group. We have them, like in my estate, the COVID, the COVID brought
Yeah.
that out a lot in Nigeria.
Okay.
And yes, a lot. We have a lot of pocket of exercise group in Lagos. Everywhere you go in Lagos, you see them exercising, even with weekdays. Like in my estate, we do it a lot. But because of insecurity now, that has taught down a little because of insecurity. But a lot of people are doing that. But we want to still do more, like you said, to put it out there, let the people know that exercise is number one in managing any illness at all they are living with.
I think the professor might want to even, bring that up somewhere, because this education, this
is key.
Is structured as well.
Yes.
And it's structured because the nurses have to be trained. It's not just something that you tell the nurses to go and do. They need to be trained.
For years, they are trained. We had some stakeholders company who were doing that. That's how I became a diabetic educator. They were always educating the nurses, but for some years now, this whole terrible things happening in our country has affected a lot of things. The nurses are not getting that training they used to. If you notice, IDF did a campaign that nurses are key in the lives of people living. That was what we did last year, and that was the last 2 years. That was the topic for IDF World Diabetics Day, that nurses matter, and we need to invest in their training. So we are pushing for it, and we are hoping that the government, because the government involvement is not there, that's why we are having all this setback. But by God's grace, WHO is forcing them to honor, because they agree to the 2030 that health for all by 2030. So they signed and they agreed to that. So they are compelling them, they must do that.
Thank you.
I'm very hopeful all will be well.
Thank you very much for that, sharing your journey, the encouragement, the information. That's been very enlightening. Thank you so much for that, Lion. Okay, I know we had so many questions after some of the speakers. We're going to take them after just a short message from John. So just give me 1 second. John, are you on? Are you able to speak, or should I go to plan B? Raise your hand, John, if you're still on here. Otherwise, I'll go to plan B. Okay, I'm going to plan B.
I think we should plan B. Plan B.
All right.
Everyone, my name is John Akere Sangodo, and I am the project manager for Gintavenes Health Foundation. And we're delighted that you've joined us for this knowledge sharing session and have stayed to the end. But before we round up for the evening, finally, I would like to say a few words on behalf of the Board of Trustees, and then give a vote of thanks to our speakers, our partners, and our sponsors. So Gintavenes Health Foundation is a health-focused non-profit set up in 2018 to conduct humanitarian interventions in the healthcare sector. Our interventions take 3 forms: manpower development, public awareness, and philanthropy. I was touching manpower development. We conduct medical trainings and medical seminars for healthcare professionals and help them upskill in different areas of their on-the-job ability in many areas. Then regarding public awareness, we have consistently used our voice, our platform, our activities and our events and all that to raise awareness for certain public health issues and empower people with critical information. Then finally, for philanthropy, our philanthropic initiatives are aimed at the impoverished millions of Nigerians who can't afford quality healthcare or have little to no access to quality healthcare. So what we do is we donate medication and medical supplies and conduct free medical training, free medical examinations, and free medical testing for these people who can't afford it. And all of these initiatives, regardless of what form they take, they are made possible by the kind donations of well-meaning individuals and organizations. Which brings us to the next point. It is in the spirit of this that we ask you to consider making a donation to Gintavenes either by a direct Naira deposit to our Stanbic IBTC account, Stanbic IBTC Gintavenes Health Foundation, account number 0028901410. I say again, 0028901410. Or if you go online and use the Giving Way platform where we have a presence. Giving Way is it's a reputable, world-renowned coalition of charities and non-profits. Okay, and they have a very safe process for accepting donations on behalf of the charities that are connected to them. So what you do is you go to the givingway.com, which is givingway as one word, GIVINGWAY.com. And when you get there, you search Gintavenes, and then you'll be taken to our landing page. And at the landing page, you will now be able to make any donation that you wish in your local currency. And it's very easy. You use your debit card or your credit card or whatever form, but it's entirely safe and easy and convenient. So finally, I would like to say a very big thank you to all the speakers who have spoken today. Their presentations were excellent as always, and we are grateful to them for donating their time and giving us the benefit of their expertise and their experience. So we say a big thank you to the speakers, and we say a big thank you to our perennial collaborators and sponsors in Victory Drugs Festac Town. Victory Drugs is 57A 11 Road, opposite 111 Road, Festac Town. And Encapsulate Healthcare Solutions, who have also kindly helped and let us use their Zoom platform for these meetings. So we encourage you all and enjoin you to keep attending these meetings and spread the word on our behalf. And let your friends and family know, and other people that that might be inclined to helping out and contributing in any form, any way, shape, or form, via any of the channels that we've spoken about. I've left the link in the chat room for those of us who may be inclined to make a donation. And finally, if we want to watch back any of this, the whole session, because we've been recording this live, this knowledge sharing session, and we're going to upload it to our YouTube channel. You feel free to go over to YouTube and search Gintavenes, then go to our YouTube channel. You'll see our catalog of content where you can watch either this one back, and if you've missed anything that the speaker spoke about, or you can watch any of our older videos and all that. And please like and share and subscribe, so the channel grows and we get attention. So thank you very much, everyone. Enjoy the rest of your evening and the rest of your weekend, and stay safe. Good night.
Okay, don't go yet. We're going to be, taking the rest of the questions we're not able to attend to earlier on. If the speakers could please have their videos on so I can see where you are and spotlight you as we take the questions. Dr. Gail, Prof. Okay. All right, I can see Dr. Gail. And then Prof. Okay, there you are. I can see you. All right. And I've added Kemi and Fumi to the spotlight as well. All right. So first question. What is the link between type 2 diabetes and high blood pressure? Anyone can take that?
Okay, you want me to go first? All right.
Yes.
The link between diabetes and high blood pressure is that both of them, first of all, they are non-communicable diseases. And the risk factors For the two of them, they share a lot of common risk factors. I'll give you an example. A person who is sedentary and puts on a lot of weight and becomes obese is at risk for hypertension, is also at risk for diabetes. Okay. Sorry. Then a person who consumes a lot of salt, maybe through fast food, is also likely to consume a lot of sugar. Because if you are taking like meat pies, sausage rolls, pepper soup, suya, you are taking a lot of calories that has a lot of carbohydrates, you are taking a lot of salt. And if you are sitting down for hours on end, you are also likely at risk for both hypertension and diabetes. So they are similar in the sense that Western lifestyle, Westernization, sedentary lifestyle, overweight, obesity, they are common risk factors. So it means if a person develops high blood pressure, usually it's just a matter of time, they will also come down with diabetes, and vice versa. If a person develops diabetes, many of them will develop hypertension. In my typical clinic, between a third or 2/3 of the people I treat for diabetes are also hypertensive. And when I ask my colleagues in cardiology or nephrology who manage hypertension, they tell us that about a quarter or a third of their patients too have diabetes. So they are both related. And the risk factors and the lifestyle changes that apply to hypertension also apply to diabetes.
Dr. Gail?
Right, so I do apologise to everybody, but in fact, it was my router that went down and it took me half an hour to get back into the talk. But to add to Prof's comments, I think I talked about the waist circumference. So life is unfair because if you put on weight around your middle, that's just where you put on your weight. But if you're in that category, then we call it cardiometabolic syndrome as described by Prof. You are more likely to get diabetes, you're more likely to get high blood pressure, you're more likely to get the cardiovascular complications. So you do, there's been a lot of talk, and it was brilliant listening to our last speaker, Leon, that says, you know, she clearly demonstrated, well, I've been doing all these things. And then I suddenly realized, well, I thought I was doing the activity, but I wasn't quite doing it in the right way. And isn't that amazing to listen to the fact that her insulin dose was halved, her tablet dose was halved, because she just puts her activity some more. And the number of people who talk to me about, I'm taking so many tablets. Well, actually, if you go back to the basics, Prof gave a really brilliant outline before I was booted out of the system about activity and healthy eating. And I think sometimes people almost need to be encouraged to have the courage to do it, you know, because you can almost end up feeling powerless, and given the advice to do it in a safe way. You know, Leon just described about getting good foot support, understanding how she could do it in a safe environment. And then you feel empowered. I can make changes. I'm working with my healthcare professionals. They're not telling me what to do. And that's the thing about diabetes. You live with it for a very long time. So you have to have this partnership. But it's, you know, so some things aren't fair. But even if you put on weight around your hips and thighs, we know in the Black community, blood pressure issues is much more common. So you can either decide you're going to deal with it, or you can go into denial, but it's not going to go away. You know,
okay,
you
we
can
mentioned
control
about
it.
salt.
Yes. Well, Prof mentioned about salt.
Yeah,
so,
Prof mentioned about salt.
Yeah.
So can we talk about salt? Adding salt when you finish cooking, where salt may be hidden, as it were, seasoning and things like that.
Right. So the interesting thing around salt is that if you can reduce your salt intake, and they say in the UK, we would talk about try to cut back on some of the obvious salty food. And I apologize because I may not know enough around the Nigerian traditional diet to know which things are very salty. But if you avoid things like, as Prof said, processed foods, those foods taste nice because they lace them with sugar and salt. They're full of rubbish, but we love the taste. So you have to kind of roll that back. I can see Leon smiling at what I'm saying, but it's true for all of us. And the interesting thing about lowering your salt intake to a lower level, is that's as good as one of the blood pressure tablets. It actually matches studies for a blood pressure tablet about how much it can lower your blood pressure. So if you're taking all these tablets for your blood pressure, but you're piling the salt on, you're just counteracting the benefit of any of the tablets. So again, it goes back to saying, how can I be a healthier version of myself? How can I cut back on some of these salty foods? No one's ever going to say you're not going to have them, but they have to be the occasional treat, not the everyday. And that's the power of looking at the basics, because then the medications work better. I always tell people, you can out eat anything. If you eat too much, it doesn't matter what I throw at you, I won't control your diabetes. That's why we always go back to, that's why Prof started his conversation about activity, healthy eating, and then the medications can work well with them.
Prof, do you want to say anything about salt? I'm targeting seasoning, actually. That's why I'm asking the question. I'm asking on purpose.
Yes, actually, many people don't know that salt is hidden in many foods that they do eat. For instance, there is a popular food that is eaten in Nigeria, call it noodles, and it comes pre-packed with a lot of seasoning, plenty of salt inside some small sachet that's come with it. And people open it up and pour it inside. Also, if you are eating a can of sardines, it's preserved with salt most often. So people often eat a lot of this salt without knowing. And the reason why salt is a lot inside these meals is because they are there as preservatives, which is why I was saying that try not to eat junk food, because these are food produced in commercial outlets. So it has to be preserved with salt. And they could add salt, they could add Knorr, Maggi, Onga, or with different names. And then some even go further to add monosodium glutamate, which also contains salt. And then a person tells you, I don't take salt at all, but I put Maggi in my food. Then you are taking a lot of salt. And I see some ladies, when they are cooking, they just crush 3 or 4 cubes of Maggi and pour it inside the food and say, well, I didn't put any salt at all inside. But you've just put in 4 cubes of salt. So salt is a very big culprit. And actually, the other reason why the fast food outlets put a lot of salt there is because when food is salty, it tastes sweeter. And so you're likely to eat more quantity. So we should try to, that's why I said we should try to cook at home, eat at home, because you have control over the salt shaker at home. You can decide, I'm not going to put any added salt at all in my meal. And that will go a long way to bringing down your blood pressure, just as Carol just mentioned. And it's actually cheaper because there is no blood pressure medication that is cheap. But just taking away salt, you're saving money. And if it's not too sweet, obviously you're not going to want to eat too much anyway. So if you visit a home where people don't eat salt at all, initially, you'll be taken aback, but you eat less food. And gradually you get used to it. And then you don't even notice that there's no salt inside. And that does a lot of good to you. So please, if you think you're not taking salt, but you're adding all the different cans of sardine, or you're eating a lot of canned food, or pickles, or you're eating things like Lay's and Pringles, they are all loaded with salt. Or you're taking suya, it's seasoned with salts. Or you're taking, sprinkling Maggi on your food, you're adding extra salt. So try as much as possible to use non-salty seasoners. I mean, things like maybe ginger, things like garlic, onions to spice your food. Those ones are safer and they're healthier on the heart. And you'll be saving yourself from hypertension and then to a lower extent, diabetes.
Thank you. Lion, did you want to say something? Okay, unmute yourself.
Okay.
You're muted again. I don't know what happened. Go unmute yourself.
It's again.
All right, there you go.
Yeah, I want to add to what my prof and Dr. Carol have said. I want, a lot of people get confused and say salt, the children need salt. I don't need it. It's not true. What you eat, your children eat. I'm living with diabetes since I started giving birth to my kids. They eat what I eat. They don't take mineral. My kids go to party. People ask me, how do you do that? I tell them, you teach them. It's consistent. Everything is deliberate. I have 22 to 12-year-old children, so they are grown and they are girls. Everyone knows what it means to manage a girl child, and they are very beautiful. So they live healthy from this age. So you incorporate them. So we don't eat salt. We eat very little salt. We cook plantain and yam without salt. And the sauce you make it with little or no salt and very little oil. They do the cooking too. So I brought them in. I taught them these things. So they are living, they are doing what I am eating. Living with diabetes means you are eating healthy. Living with hypertension means you're living healthy. That's what it means. And when you change those lifestyles, you see that people around you are living healthy. So salt, I have not been giving my family since I discovered that Indomie or whatever, the noodles, the popular, like the prof mentioned, is poisonous. I took it out of my family diet 5 years ago. So my kids will never think of that. They just look at it, tell you, you are not eating healthy, you are eating Indomie. And everyone that comes to my house knows that. So I had a party, nobody is expecting mineral. So that is how you teach people that what they are seeing you are healthy, and you are teaching them. And my kids are going to get married. They're going to teach the man they are meeting. Their friends know that. So I will beg everyone here, don't say it's difficult. I'm seasoning my meat with garlic, ginger, and all salt. I cook my soup and stew with iru, our locust bean. By the time you add all those ingredients, you will see that the vegetable and the tomatoes you are cooking with the onions, they have very fantastic flavor. No oil, little oil. So it's just discipline and mindset. That's what I want to add. It's just discipline and mindset. Thank you.
Thanks a lot, Lion. Thank you. Question for the podiatrist. How often should someone that is living with diabetes have their feet checked? And if they're based in Nigeria, I think maybe Prof can come in after you answer that question, because we've said before that there are no podiatrists in Nigeria at present. So what happens? So Fumi and Kemi first, and then Prof.
Okay, I'll go first. So you have to check your feet, like Prof mentioned and Fumi said earlier. You have to check your feet every day. When you wake up, you check it. And if your work involves, maybe you work in for example, bricklayer or carpenter, whilst you're at work, I would say take a break, take off your shoes, especially if you have neuropathy, just to make sure you haven't, have developed any blisters or cuts. Take off your shoes and check. And in terms of seeing a podiatrist, depending on your risk factor, they'll be able to determine whether you have to come like every 2 months, 3 months, or yearly. But anytime you go to see your podiatrist, they're always checking your feet anyway. But because you spend more time with your feet anyway, so I would advise you check your feet every single day. I don't know if Fumi wants to add more to it.
What I will add to that is just as you've said, it depends on the person. Obviously, it depends on their risk factor. Some people we don't even see, we just see them annually. If they're fine, eyes are good sensation, everything is well, and they can reach to do their feet, it's safe for them to do it, then that's fine. Some people have lesions. If they have corns, hard skin, we sort of tailor it according to each person. But I'll say the average, if you're looking at maybe older people that can't even maybe see their feet or reach their feet, is 3 to 4 months, just even to maintain just the general nail care. But if they have corns or other issues, risk factors of maybe had previous ulcers, that sort of thing, then of course we'll tailor it according to their need, and it might be less than 3 months. So the average I'll say is about 3 monthly.
Okay. Prof?
Yes. For the patient, he should check his feet every day, just as I mentioned earlier, and just like Fumi and Kemi mentioned. And for specialized visits, like to the podiatrist, just as they also mentioned, it depends on the risk factors. If you're a young person, you're 20 years old, diabetes is just 1 year or just a few months, you don't need to be going there every 2 months, except if you have foot deformities. But if you're old, had diabetes, hypertension for some decades, then you need to have your feet checked more frequently. You may even need to have some procedures such as vascular Doppler or biotensiometry or x-rays of the feet from time to time, depending on the abnormalities present. But I would say that people that have diabetes, each time you go to see your doctor, your endocrinologist, or your primary care person, if the doctor just told you to come in, sit down, wrote a prescription and is hurrying you out, ask him that, doctor, would you not like to see my feet? Or you just take the first step. Take your shoes off, take the socks off and say, doctor, I've already taken my shoes and my socks off. Can you just let me look at my feet? And when they do that, when the doctor does that, usually doctors are so busy, so they don't want to do so. But if you've already gone half the way by taking off your shoes and putting your feet in front of him, he will have to check because he knows what he's looking for. He's going to check the pulses, he's going to check for callosities. And unfortunately, in Nigeria, we don't have podiatrists. So usually it's the nurses and the doctors that have to fill in, except during workshops or programs when people like Kemi and Fumi come in with their colleagues, and we do have foot camps. So let your doctor look at the feet because he or she will know what to do and will also know what advice to give. But on your own, check your feet every day.
Okay, foot checks every day. Thank you. Next question was, does having boils consistently mean you are diabetic? That's one. I want to do two questions in one. So does having boils consistently mean you are diabetic? And what is the cause of prolonged diarrhea in someone who has type 1 diabetes? Who's taking it?
Well, maybe Carol should take it.
Oh, shouldn't I defer to the prof? So boils. So boils can be a sign that someone has diabetes, but it's not 100%. And the reason for that is if your blood sugars are high, bacteria love to grow where there's more sugar. So it's well recognized that somebody with diabetes, if it's not well controlled and their sugars are very high, they're more risk of any kind of infection. That could be boils, it could be urine infection, it could be thrush, it could be skin infections. So it could be a sign of diabetes, and it would be recommended that you should go and have an assessment, particularly if it's something that keeps on coming back. But there can be other reasons. But it sometimes can be one way that diabetes will show itself. And then remind me of the second question, the diarrhea in type 1.
Yes, prolonged diarrhea.
Okay.
What could be the cause?
So that's quite a bit more complex. It could be, so there's two things. If you've had your type 1 diabetes for a very long time, sometimes one of the complications can affect the nerve endings throughout the bowel, the stomach and the bowels. And so diarrhea can be one way that it shows itself. It can also be then other symptoms related to that might be that people find a mismatch with their blood sugars. So they eat, but actually their sugars don't go up the way they used to, or they can feel very sick because the food's staying in their stomachs for much longer and it's not passing through as well as it should. So they take their insulin, and in the past their sugars would have been matched to it, and then because the food's not passing through the stomach and sitting there, then the sugars get very high. The insulin could drop, the blood sugars could actually drop, and then they suddenly can go high after. So that's something that's called autonomic neuropathy. It's actually, even for people with type 1 diabetes for more than 20 years, quite a rare complication, but it's a highly specialized complication. It could separately be nothing to do with diabetes. It could be, there are some bowel infections, giardiasis, where actually you can just get recurrent diarrhea. And then finally, people with type 1 diabetes, which is very different from type 2, could be a separate autoimmune condition, and that they're getting an inflammation of the lining of their bowels. That is more likely to be associated with some bleeding. So they might notice some blood in their stools, not just that they've got more diarrhea. And ideally, if you've got type 1 diabetes, you should be under a specialist, because it sometimes can be quite difficult to unpick what is the problem.
All right. Thank you. Thank you for that. This one I'm going to ask Prof because I don't know what dionyl is. The question was, must metformin always be taken with dionyl or dionyl? What
Okay.
drug is it?
Okay, so Daonil is the branded name for glibenclamide. And as I said earlier, the commonest group of drugs that patients have prescriptions for is the biguanides, which is metformin. The second commonest group is the sulfonylureas, of which Daonil or glibenclamide belongs to. So it means most likely if you go to a primary care person or a general practitioner or you're an insurance patient and they're going to prescribe two medications for you, most likely it's going to be glibenclamide, which is a Daonil, and metformin, which sometimes comes as glucophage. So that's why they are so commonly prescribed, like a husband and wife tag team. But there are others that you could give together with metformin. Some people take glimepiride with metformin. But Daonil or glibenclamide is one of the cheapest sulfonylureas. So if it's an insurance patient, between 60 to 80% chance in Nigeria and most countries, it will be the second medication prescribed after metformin.
All right, okay. Different, you see, different brand names. There's a different brand name here. That's why I was like, what's that? Thank you. All right. Okay. Two more questions. We're almost done. Okay, Laura, let me let you ask before I ask the final two questions. Unmute yourself.
Yeah, thank you very much. I actually asked a question initially. I don't think it was asked. The first question I wanted to ask was to Prof. The question is this. I noticed in your presentation, you said something like diabetes could never be cured. I had always grown up with the understanding that if one kept a consistently good diet and exercise, type 2 diabetes could eventually be cured. Is that a wrong understanding? That's the first question. And secondly,
more questions than we think.
Then secondly, type 1 diabetes, that's in a young child. The child, he was diagnosed at the age of 12. He's now 16. Does type 1 diabetes also predispose one to diabetic foot syndrome? That's the foot, is it neuropathy or whatever? I just want to be informed about that as well. Thank you.
Okay, for the first question, it is a wrong notion to feel that with diet and lifestyle change, you can cure diabetes. Diabetes is a progressive condition. It's a degenerative condition. Usually, by the time a person presents to hospital, he has already lost a significant amount of the beta cells, and these are the cells that produce insulin, whether it is type 1 or type 2 diabetes, and these cells don't recover. So most times, that's why I said over 90% of cases, it is something you have to live with lifelong. So there is no amount of starvation or severe dietary restrictions or no amount of exercise that can completely reverse it. You can have good control with diet, but it does not mean it is cured, because a cure means if they give you glucose in what we call an oral glucose tolerance test, if you take glucose and they monitor your blood sugars 1 hour, 2 hours after, your blood sugars remain normal. That cannot occur in a person who is as strict as possible with diet and exercise. The reason why he or she may not need medication is because of what he is doing. If he takes a soft drink, the blood sugar will spike. But if a person that doesn't have diabetes takes 2 bottles of a soft drink, the blood sugar won't spike. It will just go up a little bit and return to normal. So that's why we say that there is no cure for diabetes. In more than 90% of people, they have to live with the condition. The second question is, if a boy or a girl, 12 years old, has diabetes and does not manage it properly, that person can still have a diabetic foot ulcer or gangrene, even in that young age. And I've seen a few young people, teenagers, who have lost a limb to diabetes. And I've seen also those less than 18 who have lost their life to diabetes. So the age does not protect you from any of the complications. So if you know someone who is young, he or she should take the diabetes as seriously as a person who is middle-aged or old.
Dr. Gail, anything to add to that?
All right. I do apologise because as you saw, there's a bit of chaos going on behind me, getting rid of the dogs. So I didn't fully understand the questions. What I would say, and it's one of the reasons why people are testing earlier, one's assumption in the past was that somebody diagnosed age 12 had type 1 diabetes and needed treatment with insulin. We know, and particularly in the States, there are increasing number of young adolescents and children being diagnosed with type 2 diabetes. And some of the data that is coming out, which is very disturbing, and they do tend to be very overweight, I'm going to be fair about that, is that they actually get their complications earlier than the people with type 1, because they're more prone to blood pressure, they're more prone to heart disease. So what Prof was saying about you still have to look after your diabetes, whether it's type 1 or type 2 when you're young, is absolutely true. And that's very hard to take, 30 or 40 years. I mean, when the first cases of young people presented with type 2 diabetes started appearing in England, they were written up as special cases. And now it's very common and it's very frightening to me. So we still have to address that. And we all know that adolescents aren't easy to live with, even when they haven't got any health issues. So I'm not pretending that this is an easy group to look after. And I think my other comment, which echoes Prof, is that that's why we talk about type 2 diabetes remission, because as Prof says, if someone does all the really healthy lifestyle stuff, there's good evidence, particularly early, whether they're pre-diabetic or type 2, that they can normalize their blood glucose values. But the reason we talk about remission rather than cure is that as soon as if they were to resume all the behaviors that cause them to develop type 2 diabetes, it will just come back. So that's why we talk about remission rather than cure.
Great, thank you. Anyone else want to make any comments or anything to that? All right, final question. Again, back to herbal medicine. So someone's asking, are there no herbal medicines that can help one maintain good blood pressure? And I think it's while you were speaking, Prof. And he said, are you saying that people living with diabetes should not take herbal medicines?
Well, the answer is simple. I tell people when they want to drag me into the discussion of herbal medicine, I say, well, I'm not a herbalist and I'm not a traditional medicine practitioner. However, I've been treating people with diabetes now for about 30 years, and I've not seen anyone who has come back to tell me that this herb cured my diabetes. And those who even say it did, I just tell them to go and do the simple tests, and I show them the results. That, sorry, bad news is your diabetes is still there. See your blood sugars. So I do not know of any herb that cures diabetes. Some people say the herbs alleviate some symptoms, but that is subjective. Some people say the herbs reduce the effect of some of the complications they already have, but that is very, very debatable. So there is no herbal cure or treatment for diabetes as of yet, to the best of my knowledge.
Dr. Gail, anything to add?
I think I would echo what Prof says, but however, and my caveat to that is, like him, I am not a herbalist. And therefore, I can't tell you that I know what herbs do. We know that some herbs have found the basis of tablets that treat different conditions. But what I would say is, certainly in England, I have lots of people come to me saying, can I use this herb or not? And sometimes our pharmacists can answer that question. But what I say to them is if I recommend a medication for you, what is the first question you ask me? And to a man or woman, the first question they ask me is, what are the side effects?
That's it.
All right. So in medicine, there's a long process for a drug to come to market. We have to have a good understanding of what the benefits are, what the risks are, how it can affect you. And I give people those percentage figures. And then I say to them, and they'll say they go and buy these herbs over the counter. And I say, do you ask the person in the shop, the chemist or the herbalist, what the side effects are? And they go, no, because it's a herb. And I say, well, there are some herbs that can kill you.
Absolutely.
So if you don't have that same, it always fascinates me that I know I have to be on my game. I need to know about my products. I need to be honest about what the risk and benefits are and how I think it will work. But people will go to a herbalist, a chemist shop, a health food. In England, we have loads of health food shops, and they will pick up anything at any strength, and they wouldn't dream of asking the person at the desk or emailing the company to say, well, does this product have any known side effects? What are the risks of me taking it? And I find that fascinating because it's a herb. Now, I'm not going to say that there aren't herbs that are beneficial, but they don't have the same rigor applied to them as medicine. So one has to be careful.
Absolutely. So, Nkiruka, very quickly, please. I have one last question, which is diabetes preventable? Which we will answer after Nkiruka. Nkiruka, you don't want to ask anymore? Or?
No, I do.
Okay, go ahead.
Good evening, everyone. Very commendable presentation from all our speakers. Just one suggestion. Can we have the next presentation on type 1 diabetes to enlighten people more, because there seems to be some form of confusion with type 1 and type 2. Not everyone understands. I'm a type 1. I'm a medical personnel. I live in Glasgow. And I've lived with diabetes for 34 years now, since I was 7. And I've lived well with it, and I understand the disease. So we need more, especially for our Nigerian community, because there's so much misconception about type 1 diabetes. Just a suggestion.
Okay, please, can you send me your contact details? I will look into that.
Could I just answer one question? Because somebody in the chat, and it's gone now, so I apologize about the gentleman's name, was asking about metformin slow release, and he was concerned that there'd been some publicity around it having maybe some cancer properties. So I did answer him directly in the chat, and I answered it to everybody, but I looked it up as well. Now, in America, they had to withdraw several brands of metformin SR. I thought it was only one, but when I went onto the website, and the FDA has it all there, it was about initially 4 or 5. And there had been if you like a contamination of those particular companies. So it turned out in total, when I looked at it, that there were initially 5 companies that had to withdraw their metformin MR, and then there were maybe another 3 or 4 after. Some of them were single batches. Some of them, they had to withdraw it for a period of time. I know during that time when that signal was, so I said to him, there's regulations of medications. Companies have to have regulators come in to assess their products, check their manufacturing standards. And I think that's how it came to light. But I do know, and all the companies that were mentioned were American companies. In England, we never had that recall. There was no British company, for example, where that was an issue. And the FDA make it very clear that it's something that shouldn't be in the metformin. And it suggests to me that maybe some of the regulations, or how those companies set themselves up, weren't to the right standard. So metformin per se doesn't cause cancer. In fact, interestingly enough, there's some big studies being done looking at it as a cancer treatment. So I just wanted to reassure people that they shouldn't get frightened and suddenly stop their metformin. Even the FDA said if it was the slow release version of metformin you're on, you should continue taking it till you could see your healthcare provider and to be changed. And that would be to a brand where there wasn't an issue. And that does happen sometimes. Some companies have had problems with their insulin. They've had to shut down production of a particular factory and go through processes. That's why they have heavy regulations in these areas. But I just wanted that because I didn't want people to get frightened and then suddenly stop metformin, because it's an incredibly powerful drug and incredibly beneficial.
Thanks for that, Dr. Gale. So the last question, is diabetes preventable?
I'm going to leave that to Leon.
Lion, very quickly, please. Our time is, yes, so that we can answer the last question.
Okay. I just wanted to add to what has been said about podiatrics and how to care for your feet. I I just want to add to it because somebody asked, people if you're living with diabetes, please, how often do you check your feet? Every day. You massage your feet with ori, because here in Nigeria, so many of us are Muslims, because they always have to wash, they have to dip their feet in water. So they have foot ulcer in between their toes. We have found that in many people living with diabetes, and even those who are not. And that becomes an angle where they get the infection from. So people should use ori to rub their feet and also dry in between their toes with a dry towel, especially those who we are in Nigeria, we're not in UK. Nigeria here, where we have more of the audience. They should please put that into consideration. And then the prof said something that you should confront your doctor. We don't do that here. If you do that, they will not see you again the next time. Prof knows that. So they won't see you. They say you are being rude. So what they should do is to maybe, if you have a diabetic association, they should please meet. We usually check. If they don't, then you speak to the nurse. A nurse is always a better person, a calmer person to communicate with, and tell them, please, nurse, can you help me check my feet? Or when you see that the doctor is very happy, say, please, I want you to please check my feet, because they claim they are under pressure. So please let them not put themselves at risk. Now, if you have my contact, I've already put it there. Just call me when we are having an outreach. We usually do that. We can also check you. And we do it often in our diabetic association meetings. We check our feet always, and we encourage a lot of people. And another thing, please, everyone here, we don't like to be called people that are diabetic. We are clients. We are not patients. We are clients. And we are also people living with diabetes. Please, because I'm living with it. I don't fall sick every day. So it's just a condition which I'm managing. So most of my doctor call us clients. That's why I tell them, call me clients. Don't call me a patient. So that helps to push away stigma and discrimination. That's what I just wanted to add. Thank you very much.
Thanks, Lion. Thanks. So, yes, last question. Is diabetes preventable?
So Lion answered that question when she talked about it. She said, if I eat well, if I demonstrate the right lifestyle, my children will have the right lifestyle, because children on the whole will copy their parents. And all the studies that show that, we know that diabetes runs in families. If it runs in your family, then you have maybe 40 to 60% chance that you'll develop it. But if you live the healthy lifestyle, the activity, the healthy eating, the sort, you will delay or prevent the diabetes. It will take much longer to show itself. And so it's one of the times that I talk to, because I do diabetes pregnancy, and I talk to, as part of our education for our ladies who develop diabetes in pregnancy. And I say, because they all want to do the best for their baby. So they take all the information on board. The first person you see in my clinic, if you have diabetes in pregnancy, is not me, it's not the diabetes nurse, it's not the obstetrician, it's the dietitian. Because you have to get on board with a healthy eating. And I would say 99% of women will do what it takes because they want their baby to be healthy. And I say to them at the end, you know what to do. You sure for yourself how you could control your sugars by being healthy about what you eat and increasing your activity. And I'm not saying they didn't need medication. Many of them do. But I say, if you continue that, you show that example to your children, you help to start breaking the cycle in the family, because you can't change what you inherit. You can't change how old you are. But what you can change are things around your weight, your activity, the lifestyle. So if you eat healthily, then your children will eat healthily, because they'll copy you. Like you said, your children don't have a taste for salt. They probably don't even like it if they eat it now. So that's where you can help with the prevention. And then if you do get it, you can still, and you haven't had that healthy lifestyle, you can add it at any time. So that would be the way that I would answer it.
Thank you. Prof, do you have anything to add?
Yes. So I think Carol has mentioned it, and that is, you can prevent diabetes. You can delay the onset of diabetes. And for those who already have diabetes, you can prevent the complications. So there are different levels of prevention. You can prevent having it. If you already have it, you can prevent the complications. And if you already have the complications, you can prevent early death. So diabetes has a great aspect of prevention that everybody needs to major on. Thank you very much.
Thank you. And on that note, there are no more questions. That's it for today. Thank you to everyone.
Good night, everyone.
Joined. Sorry?
I was just saying good night to everybody, and I hope you found it beneficial.
Yes. Everybody, you can unmute and say hello or bye. I've allowed everyone to unmute themselves so you can say
Thank
hello.
you so much. Bye.
Thank you very much.
Thank you very much. This is very wonderful of you. Thank you so much. Bye bye.
Thank you. Wonderful.
Bye bye.